Okay. We have discussed their causes. We have discussed their effects. We have discussed what's going to happen with the heart. Okay, what kind of hypertrophy they will feel, whether it is a whether it is a concentric hypertrophy or a eccentric hypertrophy. Okay, what's going to happen in case of heart failure, whether it is systolic heart failure or the diastolic heart failure. We have discussed about the type of cardiomyopathy, which affects only the apical part of the heart. Okay, sudden release of these catecholamines can cause a vasoconstriction, and as a result, the apical hypokinesis occur, and as a result, the patient will get the dilation of the this apex of the heart, the ballooning of the apex, which is a type of cardiomyopathy. We have discussed about the hypertrophic cardiomyopathy, and in that we have discussed three factors or three things that you must consider. Okay, one is a septal hypertrophy that can lead to every symptom of the disease. Second is the ventricular arrhythmia that can lead to the death. And third thing is the systolic anterior motion. Okay, and that systolic anterior motion can lead to the obstruction and as well as the mental regurgitation. Right? We have discussed how it is, how it is different from the this chronic hypertension or the aortic stenosis. Okay, because you will get a very asymmetrical hypertrophy in case of HOCM, while in other causes you will get a symmetrical or a diffuse hypertrophy. Right? So that's how you can easily differentiate it. Then we have also discussed about the histology, okay, which is the myofibrillary disarray and the fibrosis you will see on the histology. We have discussed about the treatments, that every treatment which increases the heart volume can reduce the murmur of the HOCM or it can relieve this obstruction from the HOCM. We have discussed this restricted or the infiltrative cardiomyopathy. Okay, the stiffening of the heart will occur because of the infiltration of other tissues inside the heart, and as a result, the heart will become very stiffened. It cannot be relaxed properly, and as a result, you will get the diastolic dysfunction. Okay, even though you are having a very thick myocardium, it seems like in the when the echo of the patient, it will seems like the patient is having a very thick walls of the myocardium, but in actually it was the other tissues which are depositing over the myocardium, right? So you will have a low voltage EKG despite being a thick myocardium. We have discussed the causes, the post-radiation fibrosis whenever you do the radiation therapy in some patient in case of any cancer. Okay, ultimately the fibrosis will happen at that location. If it is a chest, then heart can get fibrosis, and as a result, it would be the restricted cardiomyopathy. The Loeffler's endocarditis, which happens because of the eosinophils, the patient will have a high eosinophil count. Okay, then the endocardial fibroblastosis, which is seen in the children only or the infants, not in the adults. Amyloidosis, sarcoidosis, and hemochromatosis. Sarcoidosis, hemochromatosis, they both can cause a TCM, dilated cardiomyopathy. In the long term, they can cause the restricted cardiomyopathy. Amyloidosis, which can be happen with with the chronic diseases or the multiple myeloma, or even the age-related also. The patient can get the amyloidosis and can get the restricted cardiomyopathy. Okay. And so now we have already discussed that two types of heart failure exist. Okay, one is the systolic dysfunction, heart failure due to systolic dysfunction, and second is the heart failure due to the diastolic dysfunction. Okay, now what condition you will call it a heart failure? Okay, what condition you will call it a heart failure? It would be whenever the cardiac output of the heart is dropped. Okay, whenever the cardiac output of the heart is dropped, you will call it a heart failure. Okay, it can be happen with a diastolic dysfunction. Okay, when the heart is not filling properly, and if the preload is decreased, then the cardiac output will also be decreased as a result, right? So you will get a reduced cardiac output and a heart failure with the diastolic dysfunction. If the systolic dysfunction occurs, then as a result, the heart will lose its contractility. And as a result, even if the payload is present, the heart is not contracting properly to eject it out, and you will get the low volume. Okay. Just give me a second, guys. Okay. So And whenever the heart failure occur, let's suppose it is a right-sided heart failure, okay, whether it is due to a systolic dysfunction or the diastolic dysfunction, doesn't matter. Ultimately, what's gonna happen? The blood and the pressure, okay, sometimes the blood, sometimes the pressure, it will be all backflowing inside the lungs. Okay, so the first symptom would be the pulmonary discongestion. Okay, the patient will get the orthopnea, dyspnea. Okay, then the right-sided heart failure will occur, and ultimately the patient will get the symptoms all over the body, like the liver congestion, spleen congestion. Okay, and the venous dilation that will have the pitting edema all over the body. Okay, so so whenever the clinical syndrome of the cardiac dysfunction occur, it will be the congestion and the low perfusion. Symptoms include dyspnea, orthopnea, fatigue. Why fatigue? Because the heart is not pumping blood, the tissues are not getting oxygen. Okay, and as a result, what you will get is the fatigue. Okay, signs can include the S3 heart sound, which is in case of a dilated heart. Whenever the systolic dysfunction occur, you will get the S3 heart sound. Okay, you will get a jugular venous distension. Like I told you, when the right-sided heart failure occur, ultimately the pressure backflow will be in the veins, like in the jugular vein, in the vena cava, in the capillaries, and you will get the edema. Okay, jugular venous distension. Two type of the dysfunction can occur. One is a systolic and one is the diastolic. In case of a systolic dysfunction, there would be a reduced ejection fraction. Why? Because the contractility is lost. Okay, and the only thing uh, uh, which affects this ejection fraction is a contractility mainly. Okay, you will get a high end diastolic volume. Why? Because the heart is not contracting. It will become dilated. Okay, it will try to accommodate more volume so that you know. Let us suppose you know in a normal heart, you have the 100 ml of volume in the ventricles. Okay. And let us suppose the patient has a 55% of ejection fraction. So they were ejecting 55 ml of blood. Now, because this contractility is lost and now they're ejecting only 30% of blood, let's say. Okay. So if you increase the preload to 200, you can still ejecting 30%, which means 60 ml of blood could be ejected. Okay. That means, your body will do everything to keep it normal, right? So because of the compensatory changes, the end diastolic volume will be increased. Okay, and because of this increase in the end diastolic volume, the heart will become dilated, and this is to maintain the cardiac output, right? Contractility is decreased. It can be happen secondary to the ischemia, like we have discussed. In case of a MI, the patient will lose certain part of the muscle tissue, and as a result, because of the fibrosis and all these things, the patient can have a heart failure. In case of a dilated cardiomyopathy, you can have a systolic dysfunction, right? We have discussed this. Second thing is the diastolic dysfunction, in which you have a preserved ejection fraction because systolic functions are, these are absolutely normal. You can either have a normal and diastolic volume, or you can have a reduced and diastolic volume. Okay, because the heart is not, properly dilating to accommodate that volume. Okay, the compliance is decreased, and because of a decrease in compliance, the pressure inside the heart will increase because the heart is not dilating to accommodate that volume. Okay, the blood has to accommodate itself in that very low volume only, right? So ultimately, the pressure inside the heart is increased. So the major cause of all the problems in case of a systolic dysfunction is a volume overload. And the major cause of problem in this diastolic dysfunction is the pressure overload. Okay, this volume will be backflowing uh, inside the lungs and inside the right heart in case of systolic dysfunction, and the pressure will be backflowing inside the lungs and inside the right heart in case of diastolic dysfunction. Okay, it generally happens second to the myocardial hypertrophy, which could be due to the chronic hypertension, could be the aortic stenosis. Okay, it could be something like that cases only. Whenever the patient gets this myocardial hypertrophy, they can always get the diastolic dysfunction. Okay, and most commonly, the right-sided heart failure, they often occur because of the left-sided heart failure. Okay, so what are the symptoms? Well, because of the left-sided heart failure, the pressure or this volume of the blood, it will be going in the lungs. Okay, there it will, and there they will cause the pulmonary congestion, and because of the congestion, the patient will get the shortness of the breath while supine. Okay, and this is known as the orthopnea. Okay, and that's why the patient generally uses the pillows or just sleep on the recliner or the chair, okay, to prevent these symptoms. Okay, so you'll get a vascular congestion. You will get a dyspnea, orthopnea, shortness of breath. Okay, the patient will also get a paroxysmal nocturnal dyspnea. Okay, because of a because of this reduced cardiac output, they will get the exertional dyspnea. Okay, breathlessness awaking from the sleep. The patient will also get a pulmonary edema, which reduces the compliance of the lungs. Whenever the edema occur in the lungs, it will reduce the compliance of the lungs. Okay, venous distension occur. You will get the crackles in the heart. Okay, and it would be a diffuse type edema. Okay, the only way through which you will be able to differentiate it with the pneumonia is that in case, like suppose in case of a lobar pneumonia, you will have the fever and a lobe involvement, right? In case of a bronchial pneumonia, you will have the bilateral lung involvement along with the fever. But in case of a heart failure, you will have the bilateral lung involvement is must because it is a heart condition. So you will get a bilateral lung involvement, okay, and along with the bilateral lung involvement, you will get, uh, and there won't be any fever. Okay, so crackles would be there, cough would be there, hemoptysis would be there because of a leakage of the blood from the capillaries. Okay, and when you do the biopsy of the patient, what you will see is the this macrophages with the brown pigments, which is the iron-leading macrophages, and these are the heart failure cells or the hemosiderin. Okay, heart failure cells. Then the right-sided heart failure occur. Okay, in case of a right-sided heart failure, you will have the congestion in all the venous system. Okay, in case of a jugular veins, you will get a jugular venous distension. Okay, the pressure will backflowing in the liver. You will get the liver congestion or the hepatic congestion, nutmeg liver you call it. Okay, you will get the cardiac cirrhosis and the liver dysfunction ultimately. Okay, and the zone 3 is most commonly involved, then zone 2 and then zone 1, because zone 3 is very near to the central vein. Okay, then the peripheral edema can also occur. Okay, you will get a pedal edema because of this increase in the venous pressure. Now, initially, when all these systems are not, when all these symptoms are not happening, you have the lymphatic drainage increased. Okay, all the blood will be leaking from the vessels, but all this blood, all this fluid which is leaking from the vessels, it will be drained by the lymph vessels. Okay, so you won't get any symptoms. Only when the lymphatic system is failed or uh, you know, overcome by the leakage of this fluid, only then you will develop all these symptoms. Okay, very important to know. So if just step one asks you, the patient is having a heart failure, but even after that, he's not developing any symptom of the heart failure. Why? Because of the lymphatic drainage. Okay, these ANP, BNPs, all of these things will become later in the picture. Okay, but before that, there would be the lymph thing. Okay, then if we draw the pressure volume curve for the heart failure with reduced ejection fraction, what's going to happen in the reduced ejection fraction? You will have a high volume, right? And if you have a high volume, you of course going to have a high pressure, because if more volume of blood is there inside the heart, you will have the high pressure, of course, because of that blood. So as you can see, the end diastolic volume is increased at that point, and as well as the end diastolic pressure that corresponds to it will be increased. Okay, and because of the reduced ejection fraction, and reduced this contractility, you will also have a high end systolic volume. And as you can see, this line representing my contractility, it is down, right? So contractility is decreased, and diastolic volume is increased, and and systolic volume is increased, right? And the pressures are also increased because of increase in the volume. So now my heart is functioning at a very high volume and reduced this contractility. In case of a heart failure with preserved ejection fraction, because your contractility is normal, but you're having a stiffness of the heart, and now your heart is not able to dilate properly, you're having a high pressure with the normal volume. Okay, so high pressure in both of these things. But in case of heart failure with this reduced ejection fraction, you're having the high pressure along with high volume. In this case, you're having a high pressure only, no high volume. So as you can see, your heart is functioning at a very high pressure, and the contractility is absolutely normal, but the compliance is reduced. So this is a difference between the heart failure with reduced ejection fraction and heart failure with normal ejection fraction. Okay, any doubts so far? Please ask. Any doubts so far?
No.
Okay. Guys,
No.
I'm taking a short break of 2 minutes. Okay. I think there is an emergency and I will be right back after 2 minutes. Okay.
Okay.
Just wait for me.
Okay.
Okay. So, any doubts so far in the heart failure with reduced ejection fraction or the normal ejection fraction?
I have one question.
Yeah, please ask.
Could you please explain me why do we have the normal and diastolic volume and diastolic dysfunction?
Sometimes normal, sometimes reduced. It depends on the heart. Okay. If it is, if the heart is kind of dilating a little bit, then it can accommodate the volume, right? If the heart is not dilating, then it won't accommodate the volume. It depends. Okay. Because size of the heart is kind of normal, right? It just your vessel, the walls become very stiff. Okay. It's all about the walls and they become very stiff and the pressure overload is happening. Right?
Yeah, okay.
It's totally depend upon the heart. Sometimes it is normal, sometimes it is reduced, but the pressure is the main thing. Like I told you, in case of a diastolic, in case of the diastolic dysfunction, the pressure is the main thing which is causing the symptoms. Okay, the congestion which is gonna happen, it is all because of the pressure. Okay, the right-sided heart failure which is gonna occur, it is because of the pressure overload only. Right? In
Yeah,
case of the
okay.
systolic dysfunction, you are having the volume overload which is causing the symptoms. Okay, and
Yeah,
if you draw the diagram, then as you can see, if this is the right sided my heart, okay, the UL has this kind of diagram and these are my arteries. Okay, this is my atria, this is a ventricle. Okay, this is the lungs then. Okay, these are the lungs. Then my right heart. Okay, and then comes the veins. So if the pressure or the volume inside this left heart is increased, what gonna happen? All of this pressure and the volume will be backflow in the lungs. Okay, when the pressure and volume backflow in the lungs, what gonna happen to the veins and the arteries of these lungs? The pressure inside them will be increased, and because of an increase in the pressure, increase in the hydrostatic pressure, they will be started leaking out of the vessels and coming into the interstitial spaces. Okay, so for the acute thing, you will get the venous congestion in the lungs. See, for the acutely, when the acute heart failure occur, okay, in the first 5-7 days, what you will see is the venous congestion only and the edema, of course. After 7 to 10 days, when you do the biopsy of the patient, what you will see is the heart failure cells. Okay, because all the RBCs or the blood which is leaked out of the vessels, it will be taken up by the macrophages. All the RBCs will be phagocytosed by the macrophages, and ultimately this hemocytin will be released. And what you will see is the heart failure cells. Okay, because of the pulmonary edema, it will be diffuse. It will involve both the lungs. Very important. In case of pneumonia, you are having just one lung involvement, sometimes two, but along with the fever only. In the case of heart failure, you will having a bilateral lung involvement without fever. Okay, and because of the edema, you will have a reduced lung compliance. Okay, you will have the cough, you will have the hemoptysis, you will have the orthopnea. The patient must sleep on these pillows, on the recliner, on the chair. Okay, and in what scenarios you will get an acute heart failure? Can anyone tell me?
MI.
MI, yeah. Just after the MI, if the patient has a sudden rupture of the papillary muscles or the biventricular heart failure, if you guys remember. And when does this happen, the biventricular heart failure in case of MI? The interventricular septum rupture, remember?
Yeah.
Okay, so suddenly you will get the heart failure. Okay, and because of this heart failure, you will get the pulmonary venous congestion. Okay, you won't see the heart failure cells in these scenarios. Only when the patient is having a chronic history, the patient will, whenever the patient is having a heart failure, a long heart failure, the patient must be having a chronic history of like 2 or 3 weeks. They will tell you that they have a progressive dyspnea and the progressive, this orthopnea for like 7 or 10 days or 20 days or even a month. Okay, so whenever the patient present you a history of month or two, then you can say the heart failure cells could be seen. But if the patient is in the acute scenarios, okay, in the hospital, and they suddenly get this heart failure. If you do the biopsy of the patient of the lungs, you will see the congestion only, not the heart failure cells. Very important differentiate. Okay. Now, after the pressure in these lungs are increased, the pressure will be backflow in the right side heart. And as a result, the right-sided heart pressure or the volume is increased, the right-sided heart failure will occur, and all the pressure will be transmitted back into the central veins like the superior vena cava, inferior vena cava, and the capillaries. So you will get the jugular vein distension. You will get the edema of the body because all this blood will be started leaking out of the veins. You will get this liver congestion. Okay, the central zone will be affected first because it is near to the central vein. Okay, you will get a splenic congestion, hepatosplenomegaly. You will get the renomegaly. Okay, and yeah, all these things. These are the symptoms. Why symptoms are occurring? Okay, what are the causes? Very important to understand this. Okay, then what is the treatment in case of acute heart failure? Whenever the patient come into emergency department, there must be an edema present in the body. Okay, and the first priority of yours is to treat the edema. Okay, and to treat the edema, you will always give the patient diuretic therapy. Okay, and what are the most potent diuretics available? What class?
Furosemide.
Loop diuretic.
Exactly. Class. Yeah, good. Okay, so you will always first therapy would be the diuretics. You will relieve the edema first. Okay, and when this edema is relieved, then only you will give the patient other therapies. Okay, acute therapy is done. You can start the patient ACE, ARBs, but please remember beta blockers you cannot give in the acute decompensated heart failure. Okay, you will only give them in the compensated heart failure. Okay, and why you give the patient beta blockers?
Pulmonary congestion.
Pulmonary congestion.
No, if you give beta blocker in the acute phase, it causes more backup
Heart
and
failure.
congestion.
Yeah, but
Heart
why you
failure.
are giving these drugs in the chronic conditions, in the heart failure?
It improves morbidity
Improve
and
the
Exactly,
mortality.
very important.
morbidity, yeah.
All these drugs, the ACE, the ARBs, spironolactone, and the beta blockers, they all inhibit the aldosterone, right? And they will all
Aldosterone.
increase and they will all improve the mortality of the heart, right? Very important. And loop diuretics and the thiazides, their combination will be mostly used for the symptomatic relief only. Okay, whenever the patient you encounter is in the acute condition, you will always first give them the diuretics, then only you will give them the beta blockers and other drugs. Okay, when the condition is stabilized. Okay, sometimes the hydrolysine with the nitrate therapy is also given. Okay, the nitrates, you guys know that they are mainly the venodilators and a slight vasodilators also, and the hydrolysine, they are mainly the arteriolodilators. Okay, so ultimately you're reducing the preload and you're also reducing the afterload. By reducing the preload, you are actually reducing the end-diastolic volume, relieving the symptoms from the heart. Okay, and by reducing the afterload, you are improving the cardiac output. So these therapies can also be given. Okay, and they have both the symptomatic as well as the mortality benefits in the patient. Okay, and sometimes a combination is also given. I don't know, they have mentioned it here. Anyways, just leave it for now.
Entrasta.
Yeah, that is a napalase inhibitor, the secretary
Yeah.
along with the ARB
Entrasta.
inhibitors. Okay, these therapies can also be given sometimes, but I didn't mention it here. Okay, no problem. They have mentioned it in the later part of the in the farm chapter. So just wait for it. Okay. So yeah, whenever you have a reduced this cardiac output because of the oxygen supply to the body tissues are lost, you will have the fatigue. Okay, you will have the backflow of the blood and the pressure, and as a result, you will get the dry cough and the dyspnea. This dry cough is very important. See, in case of heart failure, you have the dry cough and sometimes with the hemoptysis, but not the wet cough or the productive cough. Okay, this is also a very important thing. So when the left ventricle contractility is reduced, the cardiac output is reduced and the venous congestion occur. Because of the loss of cardiac output, the compensatory mechanisms will be started. Okay. And first thing is the sympathetic activation. Because of the sympathetic activation, you will have a slightly increased contractility, not very much, but a slight increase in the contractility you will get. And because the beta receptors are present on the kidneys, they will stimulate the RAS system. The RAS system will be activated. Okay, what does this RAS system do? It will increase the sodium and the water resorption, because like I said, when the contractility is reduced, you need to increase the preload so that you can somehow maintain the cardiac output, right? So for increase of preload, you need to increase the blood volume, which is done by the sodium and the water reabsorption. Okay, the systemic venous pressure is increased. Okay, it will further promote the edema, and plus it will increase the preload and the compensated cardiac output is increased, right? Because of the venous congestion, you will have the reduced right ventricular output. Okay, this further increase the venous pressure in the system, and as a result, it will further add up the edema. You will get the pulmonary edema, and you will get the impaired gas exchange in case of venous congestion. So this is kind of a summarized thing of the left ventricular contractility loss. Okay. Any doubt on the previous page?
How does the pulmonary compliance change according to the pulmonary in case of pulmonary edema?
Pulmonary edema leads to reduced compliance.
Okay, like compliance of the vessels or compliance of the lungs?
Lungs.
Okay, okay.
Compliance of the lungs is reduced.
Okay, thank you.
Okay, then comes the shock. Okay, similar to the heart failure, you will call the shock whenever the cardiac output is lost and the body is trying so hard to do all the necessary things to maintain the cardiac output, like the heart rate increase, like the vasoconstriction, all these things. Okay, so in case of a shock, you will have a very reduced this cardiac output, and as a result, the perfusion of the organ is reduced. Okay, and that's why it can damage the tissues in your body. It can cause a necrosis, it can cause anything. Okay, and that's why it is a life-threatening condition. Okay, so first thing is the hypovolemic shock. Whenever you have a reduced volume, because you need the volume to pump out of the heart, right? If you have a reduced volume, like in case of a hemorrhage, whenever you have an accident, like in case of a dehydration, okay, like the vomiting or the diarrhea or the sweating, excessive sweating, right? In case of burns, you will lose your skin barrier, and as a result, all the water will be vaporized. Okay, so in case of a diuretic therapies, if you give the patient too much of the diuretics, okay, if you get a diabetes insipidus also, okay, then all in these scenarios you can have the hypovolemic shock. If the volume of the body is reduced, the cardiac output is reduced, the body sympathetic system will be activated, and when the body sympathetic system is activated, what's going to happen? It will cause the vasoconstriction in the peripheral tissues like the skin. As a result, the blood supply to the skin is reduced. So you will get the cold and the clammy skin. Because of a reduced blood supply to the skin, you will get the cold and the clammy skin. Okay. And this is to maintain the blood supply to the vital organs first, like the liver, like the kidney, like the brain. Okay, you first need the blood supply there to maintain your life, right? Not the skin. So that's why the venoconstriction occur here and the venodilation will occur there. Okay. The preload, because the volume is so much reduced, the preload is also reduced. Okay, which is okay thing. The cardiac output is also reduced. Okay, the alpha receptors will be activated by the sympathetic system, and it will lead to the increase in the afterload. Okay, and what other symptoms would you get? Because of a loss of cardiac output, the oxygen supply to different tissues will be reduced. So you will get a lactic acidosis. Okay, and because of lactic acidosis, you can even see the patient hyperventilating to increase the oxygen in your blood. They will start it hyperventilating sometimes. Okay, in the kidneys, what's going to happen because of the shock? All of these shocks. In the kidneys, you will get the pre-renal azotemia. In the liver, you can get the ischemia. Okay, in the GIT, you will get the ischemia, right? And what are the signs and symptoms? The most common signs and symptoms will be the orthostatic hypotension. Whenever the patient try to stand up, they cannot maintain their BP because of a loss of blood volume, and what they will get is the syncope. Okay, so it is the orthostatic hypotension that you will get. Very important. Okay, and how would you check for the peripheral vasoconstriction? Which is by the capillary refill time. Very important. It is the capillary refill time. You will pinch at the fingers, at the tip of the finger, and when you release, you will check, for the redness of the fingers. Okay, when the redness is delayed, you will say that it is an increased capillary refill time. When the redness will appear very immediately, that means it is a normal capillary refill time. Okay, so whenever you pinch at a very tip of your fingers and you release it, you will see the fingers become red again, right? And this is a capillary refill time, the time taken. Okay, so this time is increased because of the vasoconstriction. It will take time to again reperfuse the fingers after this constriction. Okay, so that time is increased. And how would you treat the hypovolemic shock? Well, very simple. It is by giving the patient IV fluids. Okay, what's going to happen to the pressure in different systems of the body, like what's going to happen to the cardiac output? It is reduced. You have studied it. What's going to happen to the systemic vascular resistance? It would be increased because of the activation of the sympathetic nervous system. Okay, the pressure will be backflowing because the pressure is reduced here. The pressure must be reduced inside the lungs. So the PCWP, or the pulmonary capillary wedge pressure, is also decreased in the lungs. Okay, this pressure again will be backflowing in the right heart. The right heart pressure will be decreased. Okay, the central venous pressure is decreased and the blood volume is also decreased. Very important, right? So the problem in the hypovolemic shock is in the loss of blood volume, which is at this point. And after this point, every pressure is reducing except for the arteries, because the vasoconstriction will be happening there. It would be an increased resistance, but the pressure is of course down. The resistance is increased. Okay, the problem is in the this part. Okay, then comes the cardiogenic shock. In case of the cardiogenic shock, the problem is in the left heart. The left heart has lost its contractility, and as a result, every pressure before it will gonna increase. Okay, and the pressure after it will be decreased. So the cardiac output will be decreased. Okay, and similarly, sympathetic system will be activated. That will increase the systemic vascular resistance. Okay, the coronary perfusion pressure is also decreased, right? Because of the pressure backflowing, it would be an increase in the PCWP, which is a pulmonary capillary wedge pressure. It would be an increased pressure in the right heart. It would be an increased central venous pressure. And similar to the hypovolemic shock, you will also get an increased capillary refill time, cold and clammy skin because of our vasoconstriction in the peripheral tissues. Okay, and what would be the treatment? Treatment is to give the patient inotropic agents, which increase the contractility. Okay, all these agents which stimulate the beta receptors. Okay, very important. And then comes the obstructive shock. Okay, in case of an obstructive shock, you're having an obstruction of the blood flow from right heart to the left heart. Okay, that means the left heart is absolutely normal, but there's an obstruction of some kind in flowing of the blood from right heart to the left heart. Okay, it could be a embolism, right? It could be a case of cardiac tamponade. It could be a case of any pulmonary stenosis. Okay, it could be a case of the tension pneumothorax. Very important. So, so remember three things. Either the right-sided MI can happen. Okay, the cardiac tamponade can happen. The pulmonary embolism can happen. Okay, the tension pneumothorax can happen. You will study that later in the you know, in the respiratory section, that how will this tension pneumothorax shift the mediastinum, and because of this shifting of the mediastinum, okay, the blood cannot be travel inside the lungs. So you are having an obstruction in the flowing of this blood, right? So ultimately, because the blood now cannot flow through the lungs, the PCWP is reduced. Obstruction is air, right? After the obstruction, all the pressures will be decreased. So the PCWP will be decreased. The cardiac output will be decreased. Heart was absolutely normal. The contractility was absolutely normal. It just the preload in the heart is decreasing. The cardiac output is decreasing. You will have a sympathetic system activation. So you will get the increased systemic vascular resistance. Before the obstruction, the pressure will be rising. Okay. So you will have an increased right heart, this pressure. The pressure in the right heart will be increased. And because of that, you will have an increased right atrial pressure and an increased central venous pressure. You will get the jugular venous distension and the edema and everything. Okay, in case of obstructive shock. And how will you treat the condition of the obstructive shock? It would be by relieving the obstruction. Okay. And as you can see, the PCWP can be rise and can be fall in case of obstructive shock, and it depends the cause of the obstruction. If the cause is a cardiac tamponade, okay, then because all of the pressure in, the pressure in all the chambers of the heart is increasing, both in the right heart and as well as in the left heart. So PCWP will be increased in case of cardiac tamponade, while in case of embolism or in case of tension pneumothorax, the PCWP will be decreased. Okay. And finally, you have the distributive shock. In case of distributive shock, you're actually having problem in the vessels. Okay. You're having the vasodilation. Primary disturbance is having the vasodilation and as well as the venodilation. Okay. So problem is in here, in the arteries, the problem in the veins. You're having a venodilation, you're having the vasodilation. So because of the vasodilation, the systemic vascular resistance is decreased. And as a result, the cardiac output will be increased. That is the first thing. Because of loss of, because of the venodilation, you're actually having a loss of central venous pressure. The preload will be decreased because of the pooling of the blood. And as a result, the pressure in the right heart will be decreased. If the pressure in the right heart is decreased, the pressure in the lungs will also decrease, which means the PCWP will always decrease. Okay, so you have a reduced systemic vascular resistance, you have a reduced central venous pressure, you have a reduced preload, you have a reduced PCWP, but you have an increased cardiac output, and the flow of blood is increased so much that your tissues are not able to extract the oxygen from the blood. And as a result, they will have the hypoxia, they will have the lactic acidosis. Okay, very important. Okay, so as you can see, in case of anaphylaxis, in case of sepsis, okay, in case of CNS injury, what's going to happen? You will have a very increased cardiac output and that widespread vasodilation. And because of the widespread vasodilation, you will have an increased blood flow to your skin. And when the blood flow to your skin is increased, you will get the warmth, you will get the flushing, redness, okay? You will get that dryness, okay? Because, the sweating will be decreased because blood flow is increasing so much. Okay, warm and dry skin you will see. Okay, what about the PCWP? It would be decreased. What about the cardiac output? In case of sepsis, in case of anaphylaxis, the cardiac output is increasing. Okay, in case of and what about the afterload or the systemic vascular resistance? It would be decreasing. The treatment includes the IV fluids, of course. If it is a case of anaphylaxis, you will give the patient epinephrine. If it is a case of sepsis, you will give the patient phenylephrine. Okay. This distributive shock can also happen after the CNS injury. When your brain is died, what's going to happen? The sympathetic system is lost. Okay. So you will again have a vasodilation widespread. So again, the warmth and the dry skin. But because the sympathetic supply to your heart is also lost, you will have a reduced cardiac output. Okay. You will have a reduced cardiac output. Okay. Then again, the cardiac output is reduced. The PCWP will also reduced. Sorry. Okay. Because of the vasodilation, you will have a reduced afterload. Okay. And the treatment is that you can do anything in case of CNS injury, of course. So no treatment. Okay. Yes. Any doubt on the shock?
No.
Okay. Just look for a diagram. These diagrams are very important. They are all given in the UWorld. Okay. You just need to look where the obstruction or where the cause is existing. In case of an obstructive shock, the obstruction is in the, just before the lungs. So every pressure after that will be decreased. Okay. And, the resistance will be increased and the pressure before it will be increased. In case of hypovolemic shock, you're having a reduced pressure everywhere, but an increased SVR. In case of cardiogenic shock, the disturbance lies in the left heart. So pressure will be before it will be increased and pressure after it will be decreased. Okay. In case of septic shock, you're having the disturbance in the venodilation and the vasodilation. So pressure here will be decreased and the pressure here will be decreased. This pressure will decrease the pressure in the right hand and the lungs. And because of reducing the pressure in the arteries, you will have a high cardiac output. That would be everything. Okay. Then comes the cardiac tamponade. Now, cardiac tamponade is a condition in which the fluid which is flowing in the pericardial space is increased. Okay, which is the pericardial space which is between the parietal pericardium and the visceral pericardium. Now, if this fluid in this parietal space is increased, what's going to happen? It will compress your chamber of the heart. Okay, it will compress all the chambers of the heart. Okay, and that's why you will have an equilibrium diastolic pressure in all the four chambers. Very important. You have an equilibrium diastolic pressure equal in all the four chambers, because all the chambers will be compressed equally. Okay, so whenever you measure the chamber, whenever you measure the pressure in these chambers, you will find that all chambers have an equal pressure. Okay, and because now the heart is compressing by an outside structure, okay, they cannot be relaxed properly. And if they cannot be relaxed properly, then they cannot accommodate the volume, and as a result, you will get the low cardiac output. Okay, you will get the low cardiac output. So let's talk about the causes of the cardiac tamponade. Okay, this is a pathology that every symptom that's going to happen after the cardiac tamponade occur it because of these two things. Okay. Now, what are the causes? Causes can include a tumor metastasis. Okay, the tumor itself in the heart, the pericarditis if it happens, uremia, or the myocardial infarction. Remember, in case of MI, if you have a full wall thickness rupture, and in that case, the blood will be filled within the space, right? And you will get a cardiac tamponade. And one more cause we have studied in the previous lectures, and that's about the aortic dissection, if you guys remember. In what type of aortic dissection you can get a cardiac tamponade?
Stanford A.
Exactly. In the case of Stanford A dissection, you can get the cardiac tamponade. So as you can see on this figure A here, you were having an increased fluid within the pericardial space, and as a result, the thickness of the pericardial space is increased. And as you can see, all this fluid is compressing the right ventricle and the left ventricle. Okay, normally this thickness is very thin, like here, where my cursor is right now. The thickness would be like that only, this much only, right? But in case of tamponade, thickness is so much increased. Okay. Now, because of loss of cardiac output, you will get the hypotension. Because the pressure in all the chambers are increasing, the pressure will be backflowing in the veins, and as a result, the jugular venous pressure will be increased. You will have a distended neck veins. Okay, the heart sounds will become very distant. Very important thing. The Strabon will always mention this: a very distant heart sound or very unusual heart sound. These are the feature of the cardiac tamponade. Because of a loss of cardiac output, you will have an increased heart rate. Okay, and a very important thing that you will get in the cardiac tamponade is the pulsus paradoxicus. Very important, the pulsus paradoxicus. What is the pulsus paradoxicus? It is a decrease in the amplitude of the systolic BP more than 10 with the inspiration. See, whenever you inspire, like I told you, the blood flow in the right heart will be increased and the blood flow in the left heart will be decreased. Okay, so during the inspiration, because the cardiac output is slightly reduced, you will have a slight drop in the blood pressure in case of inspiration. Okay, and when you expire, your blood pressure will again rise up. Okay, and the difference in this blood pressure in the systolic blood pressure is generally less than 10 mm of Hg. But if you get a more than 10 mm of Hg drop in the blood pressure with the inspiration, what you will get is the pulsus paradoxicus. Now, why the pulsus paradoxicus is happening in the cardiac tamponade? See, this is your heart. Okay, and this is a pericardial space which is surrounding the heart. Okay, now normally when you inspire, the volume of blood which is in the right heart is increased. Okay, and the volume of blood in the left heart is decreased. So to accommodate this, to accommodate this increase in the volume, what's gonna happen? Your right heart will become slightly dilated. Okay, it will take up the space of this pericardium. Okay, the space which is in the pericardium, which is between the pericardial layers, the right heart will take up this space. Okay, it will expand here, and as a result, the volume of blood is accommodated. In case of a cardiac tamponade, What's going to happen? Because the pericardium is already having a so much high pressure because of this so much increase in the fluid. Now the heart cannot be dilated to accommodate this volume. And as a result, because it must be dilated somewhere, okay, now it cannot be dilated in the pericardium. So this heart will be dilated in the left ventricle like that. The right ventricle will be dilated in the left ventricle. And as a result, the volume of the left ventricle is further reduced with the inspiration. Okay, so already you are having a loss of cardiac output in the inspiration, and above that you are also having a drop in the volume of the chamber. And as a, and because of both of these things, you're having a loss of BP more than 10 in case of cardiac tamponade, and this is a pulsus paradoxicus. You guys understood it?
Yeah.
Yes.
Okay, very important thing to remember. They will almost every time mention this fact whenever they want to talk to you about this cardiac tamponade. They will always would tell you in the question stem that the patient is having a drop of BP more than 10, like 15 or 16 or 20 sometimes with the inspiration, and that's how you immediately know that it could be a case of cardiac tamponade. And they will also tell you about this distant heart sounds. Okay, the ECG, again, because your heart cannot be contract properly, cannot be relaxed properly. Okay, you will have a low voltage QRS. Okay, very important. And the important thing is the electrical alterance. Okay, because of this, this is a pericardium. Okay, and it is filled with the fluid. Whenever your ventricles contract, okay, all of the fluid which is around the atrias will be go into the pericardium, which is around the ventricles. And whenever the ventricles relax, the fluid which is around the ventricles in the pericardial space, it will be go into the atria. So because of the swinging movement of the large effusion, you will see this electrical alterance. Okay, the one peak is higher, one peak is lower. Again, one peak is higher, one peak is lower. Okay, so if you look at the QRS complex, and if you see the one peak of the QRS is high, one peak of QRS is low, again one peak of QRS is high, again one peak of QRS is low. So this is the electrical alterance. Very important thing. Electrical alterance, pulsus paradoxicus, low voltage QRS, okay, distant heart sound. These all things you will see on the examination. Distended neck veins will be seen on the examination. Okay, you will see the hypotension, low BP, low and very high heart rate. Okay, very important. And another very important thing is the very increase in the C wave. If you guys remember, I think it's C or X. Just give me a second. I'm forgetting this point. Yeah, sorry. You will have a rapid X descent, not the C. In case of cardiac tamponade, one of the important things that you will see on the jugular peaks or the pressure curve is the rapid X descent. Remember, this is the A waves, then you get the C wave, then you get the X wave, then you get the V wave, and then you get the Y wave, right? So you have a very rapid X descent in case of cardiac tamponade, and this is all because of shifting of the fluid. Whenever the ventricles contract, the fluid which is around the atria will be shifted towards the ventricle, right? And as a result, now ventricles can relax properly at some time, right? And because of the relaxation of the ventricles, you will have a very immediate drop in the pressure in the ventricles. Oh, sorry, in the atria, right? And that's why you get a very rapid X descent in case of cardiac tamponade. Very important, rapid X descent. So these are all the findings associated with the cardiac tamponade. Please remember these findings. Okay, the other causes of the pulsus paradoxicus includes your lung causes. Okay, this could be a croup. We have discussed that. It could be any obstruction. It could be a asthma. It could be a COPD. Okay, and for the heart, it is cardiac tamponade. And sometimes you also see the pulsus paradoxicus in case of constrictive pericarditis. Very important. Sometimes you also get the pulsus paradoxicus in case of constrictive pericarditis. Okay, but most commonly it is for the cardiac tamponade for the heart cause, and these are for the heart causes. For the lungs causes, you will see in the obstructive pulmonary diseases like group asthma, COPD. Okay, very important to note that. And yeah, one another important thing is no point of maximal impulse could be found on the examination. Step 1 will mention this point in the question stems, that no point of maximal impulse could be found, because normally you have a apex of the heart with a high pressure, with a high, with a high peak or a high impulse. But here in case of cardiac tamponade, because all the chambers have a equal pressure, and because all the chambers have the equal pressure, you cannot localize the maximal impulse point in the heart. Okay, so no point of maximal impulse could be found in the cardiac tempo, and that is very important to note that. Okay, yeah, that's all about the cardiac tamponade. Any doubt?
Yes. Why does pulsus paradoxus occur in asthma or COPD? I'm asking about the mechanism.
Really don't know the mechanism, but I think it is related to a change in the vascular supply of the lungs. In case of this obstructive lung diseases, you have a change in the supply, the vasculature of the lung, right? And because of this change in the vasculature, you're somehow reducing the cardiac output to your heart very much, reducing it, and so that's why you can get that.
Okay.
I really don't know the exact cause, but this could happen, right? Okay. Any more doubt on the previous page on the cardiac tamponade?
No.
No.
Then comes the bacterial endocarditis. Endocarditis is the inflammation of the endocardium. Okay, and this endocardium actually lining your valves. Okay, so whenever you have an inflammation of the endocardium, it will be an inflammation, of the endocardium over the valves, right? Okay, and whenever you have this inflammation, you will have a dysfunction of the valves. You will get the regurgitation of the valves, right? And the most common presenting complaints of the patient will be the fever only. Okay, and whenever you do the heart examination of the patient, okay, chest examination, what you will find is the regurgitation. So whenever you encounter a patient with the fever, chills, sweating sometimes, and along with the fever, you will having this murmur, you will immediately know that the patient is having an endocarditis. Only two symptoms will be there: the fever and the regurgitation murmur. Okay. So what are the causes of the bacterial and of this endocarditis? Well, the first one, you have two types. First is the acute, and second is the subacute. In case of acute causes, you're having symptoms in very acute thing. The patient must be present you within 1 to 3 days of the onset. But in case of a subacute bacterial endocarditis, the patient generally have a history of like 10 or 20 days of symptoms. Okay, because this part is kind of subacute, as the name suggests. Okay, for the acute, patient generally have a history of 1 or 3 days of symptoms only. In case of subacute, patient generally have a history of 10 or 12 or 20 days of symptoms. Okay, the acute bacterial endocarditis is caused by the Staphylococcus aureus. Okay, and it generally affects the normal valves, absolutely normal valves. Okay, most commonly it is seen in the IV drug abusers. Whenever they inject some drug, okay, in their vessels, the bacteria along with the drug also injected in your veins. Okay, because this Staphylococcus aureus actually lines your skin, actually present on your skin, right? So whenever you inject some kind of a drug in the IV route, okay, these bacteria will also travel along with them, right? And the smaller particles which are present on these drugs, they will damage your heart valves, right? And when the heart valves get damaged, they will be lined by platelets and the fibrinogen and other things, right? And on these fibrinogen and platelets, the Staphylococcus aureus can easily grow, right? And they will form a vegetation on the valves. So then you will get the the regurgitation and the fever, of course, because this Staphylococcus aureus is still in your blood, right? And whenever it is in your blood, there will be the inflammation, there will be the reaction against it, and you will get the fever. Can anyone tell me what proteins or what toxins or what mechanism of the Staphylococcus aureus is to invade the bloodstream? What thing Staphylococcus aureus uses to invade the bloodstream in order to survive in the blood? What mechanism Staphylococcus aureus has?
FC portion of IgG.
What thing?
Protein A.
Protein A, exactly.
Protein A.
And what does the protein A do? Anyone, what does the protein A do? They will bind to the FC portion of the antibodies, and by binding to the FC portions, now macrophages cannot bind to the FC portion again, right? And as a result, the opsonization is inhibited. That's a way your Staphylococcus aureus invade the bloodstream. Okay, because in the bloodstream, the antibodies must bind to the bacteria to present them to the macrophages so that they can phagocytose them, right? So that is a mechanism. Okay, so whenever you inject the whenever you inject the drug in the veins, from the veins, the drug and the bacteria along with that must be go to the right heart first, and then to the left heart, right? And while going to the right heart, they will first encounter the tricuspid valves. Okay, so the most common damage in case of an IV drug abuser, in case of acute endocarditis, it happened to the tricuspid valves, and that's why these valves are most commonly affected in case of acute bacterial endocarditis. Okay, so it is almost every time a case of tricuspid regurgitation. In whenever they want to give you a, this aureus, they will always tell you that the patient is having a tricuspid regurgitation. That's how you know this is a case of acute or a Staphylococcus aureus related. Then comes the subacute. Subacute only happen in those hearts or those patients which have a history of damaged valves, a previous history of damaged valves. It could be a mitral valve prolapse. Okay, it could be a rheumatic heart disease. It could be any congenital abnormality. It could be anything. Okay, if they have a damaged heart or damaged heart valves, then they can have a subacute endocarditis, and the most commonly one are the streptococci retans. Okay, the mites and the mutants most commonly, they will cause the subacute type of bacterial endocarditis. Okay, smaller vegetations hoti hai ye. These are the smaller vegetations, and that's why they have a very low clinical symptoms. Okay, a long duration of the symptoms would be there in this scenario, right? And the Redans bacteria, they mostly happen after dental procedure. So patient must always have a history of any kind of dental procedure, and they must have a history of any immigrant sometimes to hint you towards a rheumatic heart disease, or they can have a congenital issue also, right? Or they can have a stenosis. Maybe the old age patients could be there, right? And just after dental procedures, after 7 or 10 days or 20 days later, the patient will be in the emergency department with the fever, okay, with a prolonged fever. And when you look for the heart, they will find the murmur in the heart. So that's how you immediately know that this could be a case of Streptococcus retans endocarditis. Okay, fever is the most common symptom, and second most common is the new murmur. Okay, the patient on the retina can have a rough spots, and because of the hemorrhage, because all of these vegetations can be dislodged from their location, and they can become embolus, right? And because of this embolus formation, they can lodge anywhere. Okay, in the eyes, they can cause some microhemorrhages, so you will have a rough spots, as you can see. These are the microhemorrhages in the retinal vessels. Okay, you can have a ossular nodes, which are the ouchy raised lesion on the finger or the toe pads. As you can see here, these are some raised lesions on the fingers. These are the ossular nodes, and the ossular nodes are due to the immune complex deposition. Because you're having a bacteria in your body, the antibodies will bind to it. Okay, and they will form these immune complexes, right? And because of the immune complexes, they will deposit on the tissues, in this case on the fingers. Okay, and when these immune complexes deposit on the tissues, they will cause the inflammation. What kind of hypersensitivity reaction is this?
Type 3.
Type 3 hypersensitivity reaction, exactly. Okay, so these are the ossular nodes. Ossular nodes are due to the immune complex depositions. Okay, then you also have the Janeway lesions, okay, which are also found on the palms or the soles. These are the Janeway lesions, and these are because of a blockage of the vessel by these emboli. Okay, smaller emboli or the microemboli, they will block the vessels, okay, skin vessels, and they can cause the Janeway lesions, and they are non-painful. So in the step one, if they give you a case of endocarditis and they will tell you that the patient is having some raised and the painful lesions only, okay, that means they're referring for the Osler's note, and they will ask you the cause of it. The cause is the immune complex deposition. If they tell you the patient is having some erythematous lesions without any pain, that means a painless erythematous lesions, that means they're referring for the Janeway lesions, and it is due to the microvascular this embolism formation. Okay. Then you have a splinter hemorrhage, which is seen as some blackish lines on the nails, and these are again due to the microemboli in the nail bed. Okay, the embolus will block the vessels there, and they can cause the splinter hemorrhage. Okay. Now, because the emboli and these bacteria and the immune complexes, they are kind of systemic now. They can go to the the kidneys, and there they can cause a glomerulonephritis. Okay, they can cause the septic arterial emboli if it is a case of left-sided endocarditis. If it is a case of right-sided endocarditis, like in case of acute endocarditis, okay, you will have a pulmonary embolism. Okay, and because of this pulmonary embolism, you can have a hemorrhagic infarction in the lungs, like we have discussed previously. In the lungs, in the liver, in the testes, you can have a hemorrhagic infarction, which is a red infarction, right? So when the embolus blocks your pulmonary vessels, they can cause the hemorrhage there, they can cause the infarction there, and you can die of the infarction. Okay, very important. And yeah, so these are the two common causes. Third is the non-bacterial type, okay, which occurs in case of any cancer. Like I told you, in case of cancer, you have a very hypercoagulated state in your body, right? And the coagulation occur over the walls. The platelets, they will start depositing over the walls, and they will form a vegetation over there. Okay, non-infective vegetation will be formed. And just like the endocarditis, the patient will also have a system, will also have the symptoms there, right? Again, this vegetation can be would dislodged and can become the embolus, can cause a systemic stroke, can cause this pulmonary embolism, anything like that, similar to other scenarios. Okay, you can see in the lupus, in the SLE, you can have a Lippmann-Sack endocarditis. It is a special type. In this case, you will have a vegetation above the walls as well as below the walls. Okay, in both the areas, above the walls as well as below the walls in case of Lippmann-Sachs endocarditis, which is seen in the SLE. Okay, very important. So the fever, which is most common thing, rote spot, ocean nodules, murmur, Janeway lesions. Okay, you can also get the anemia of chronic disease sometimes, nail bed hemorrhage, and the embolism thing. Remember all of these with the endocarditis. Okay. Then you also have a culture negative endocarditis. In this case, the patient is having an endocarditis. You know that it is a bacterial type, but when you do the blood culture, you will find nothing. Okay, that means it is most commonly caused by the Coxiella burnetii, okay, and the Bartonella huntsleys, if you remember. The Bartonella and the Coxiella burnetii, we have discussed this previously in the microbiology section, that all these two bacteria can cause the culture negative endocarditis. Very important. Okay, and what this Coxiella burnetii do? What is causes? Disease name?
Q fever.
Q fever.
Q fever. And what organ involvement you will get in the Q fever?
Lungs,
And
liver and kidney, I'm not sure.
liver, lungs and liver. Okay. So whenever you encounter a patient with the pneumonia along with the high LFT, that means it is a case of Coxiella burnetii. For the Bartonella, you guys already know that they can cause what diseases? Catastrophe disease. Second is the bacillary angiomatosis, and third is this culture negative endocarditis. Now, if you remember from the microbiology lectures, we have discussed about the this enterococci, okay, which can cause the enterococci endocarditis in case of any GI manipulation. If you guys remember, whenever you do any endoscopy or or any cystoscopy, the bacteria can dislodge and can enter the bloodstream, and from the bloodstream which can reach to your valves. And if you have a history of any damaged valve, in there they can cause the enterococci endocarditis, if you guys remember. So for, so you will only suspect a case of enterococci endocarditis. First thing, it should be a hospitalized patient. Second thing, the patient must be undergoing any endoscopy or any cystoscopy. Okay, then only you will suspect the case of enterococci endocarditis. Okay, then again, Streptococcus bovis, which can again cause the endocarditis, and it is in case of any GI malignancy. If you guys remember, if you have any GI malignancy, okay, then the cancer can disrupt the mucosal barrier, and as a result, these bacteria can enter your bloodstream, and from the bloodstream they can reach to your heart, and there, if you have a damaged valves previously, then they can cause a subacute type endocarditis. So for the subacute endocarditis, you have the Ridans, you have the enterococci, you have the Streptococci bovis. Okay. Mitral valves are most commonly involved in case of subacute type. Okay, but in case of acute type, it is almost always a case of tricuspid valve endocarditis. Okay. And yeah, Streptococcus epidermidis, whenever you have a history of any prosthetic device in your body, like a valve, like a new bone, or anything like that, they will always be colonized by the Streptococcus epidermidis. Okay, so in that case, in case of any heart valve replacement, okay, they can cause the subacute type endocarditis. So whenever a patient has a history of any prosthetic device and now he's having endocarditis, that means it is a case of Streptococcus epidermidis. Then comes the native valve endocarditis. These are caused by the Haysack organisms. Okay, H for the Haemophilus, A for the Agricatibacter, okay, and C for the Cardiobacterium, E for the Ichniella, and K for the Kingella. Okay, they will all cause the native valve endocarditis. That means the native valve of the patient, the natural valve of the patient, not the prosthetic devices. Okay, actually all of them, the acute, the subacute type, they're all causing the native valve endocarditis. Okay, but this Streptococcus epidermidis, it is causing the prosthetic valve endocarditis. Rest all of them are causing the native valve. They are very rare cause of the native valve endocarditis. The most common causes we have discussed already. These are the most common causes, and these are the very, kind of rare causes of the native valve endocarditis. Okay. This is a pathogenesis in case of an IV drug abuser. Whenever they inject the IV drug, it will lead to the abrasions, and the particulate matter can enter the bloodstream along with the microorganism. Okay. The particulate matter will damage the heart valves. Okay. And as a result, the inflammation, scarring will happen. The fibrosis will happen. Fibrin will be there. Platelets will be there. Okay. And they will act as a nidus for the bacterial growth. The bacteria will adhere to the walls and they can cause the endocarditis there. Okay. Right-sided valves are at a very great risk because you inject a drug in the veins and first they have to go to the right heart. Okay. And for the right heart, for the right heart, the first valve would be your this tricuspid valve. Okay. Manifestations we have discussed. Any doubt on the endocarditis?
No.
Okay, so we will take a short break of 5 to 10 minutes here, and then we will meet again and we discuss the rheumatic heart disease. Okay.
Okay.
Okay, so we are done with the endocarditis, and now we're studying the rheumatic fever. Now, for the rheumatic fever, you first need to realize that it is a pancarditis, which means it will affect the inflammation. It will cause the inflammation of all layers of the heart, which is the pericardium, the myocardium, as well as the endocardium, right? This rheumatic fever generally happens because of a cross-reactivity of antigens, okay, with the M protein of the bacteria, which is a Streptococcus pneumoniae. Okay, there's a bacteria, Streptococcus, sorry, not the Streptococcus pneumoniae, I'm sorry about that. It's Streptococcus pyogenes. Okay, the bacteria Streptococcus pyogenes has an M protein, which is an antiphagocytic protein. Okay, and through this, and with the help of this antiphagocytic protein, this Streptococcus pyogenes can invade the bloodstream, right? The antigens which are similar to these M proteins are also found on our heart. Okay, so when the antibodies are formed against these M proteins, they will cross-react with the antigens on our heart. And as a result, they will cause the inflammation there. And this is the rheumatic fever. Please note that it is a consequence of only the pharyngeal infection with the Streptococcus pyogenes. Okay, only the sore throat when happens with the Streptococcus pyogenes, it can cause the rheumatic fever. Okay, the Streptococcus pyogenes can also causes the skin problems, like if anyone remember impetigo, right? So if you have the impetigo, you can have either if you have the impetigo, then you must have the PSGN only, the post-streptococcal glomerulonephritis, not the rheumatic fever. But if you have a pharyngeal infection, the pharyngitis, then it can cause a rheumatic fever as well as the uh, PSGN. Okay, so it is a late sequel of the disease, which means when the disease is over, okay, then this complication happens because of the cross-reactivity with the antibodies. In order to diagnose the rheumatic fever, you first need to detect the anti-streptolysin O titer or the anti-DNase B titer. Okay, these are the antibodies against the toxins of the Streptococcus pyogenes. Right, when the infection is over, you have the antibodies against these toxins. You can detect these antibodies and you can tell that the patient is having a previous history of the Streptococcus pyogenes infection, and now he is having the symptoms of the uh, some symptoms related to the heart. That means it is a rheumatic fever. So to diagnose rheumatic fever, the symptoms must be present, and along with the symptoms, you must have the anti-streptolysin O and the anti-DNase B titer. Okay, high pressure valves are most commonly affected. Okay, for the endocardium, I'm only talking about the endocardium. For the endocardium, the high pressure valves will be affected first. Okay, so the mitral valves are most commonly affected, then the aortic, and least commonly the tricuspid valves. Okay, and this rheumatic fever will only be seen in the developing countries, so patient must be having a history of immigration. Okay, whenever the step one want to give you a history of rheumatic fever, a case of rheumatic fever, they always give you a history of immigration, very important. And now let's discuss all the things which are happening in case of rheumatic fever. So like we have discussed that, and there is a pancarditis in case of rheumatic fever, which means all the layers of the heart will be inflamed. First, there will be the endocarditis. Similar to the endocarditis, we have discussed previously, patient will have a fever, patient will have a regurgitation. Okay, at the acute onset, at the time of symptoms, the patient will be having the regurgitation. But soon, the healing will occur, the scarring will occur, and the calcification will occur. And because of this calcification, this regurgitant valve will become the stenotic valve. Okay, so initially there will be a regurgitation. After some time, after years later, the patient will have the stenosis. Very important, the first thing. And most commonly, mitral valves are involved, then aortic, and then the tricuspid. Second thing is the myocarditis, which is the inflammation of the myocardium. Because of the myocardial inflammation, you have the dilation of all the chambers of the heart. Okay, both the atria and both the ventricles will be dilated, and that's why you can get a heart failure with reduced ejection fraction in case of this rheumatic heart disease. Okay, when you do the biopsy of the patient for the myocarditis in case of rheumatic fever, what you will see is the granuloma. Okay, and the granuloma in case of myocarditis, in case of rheumatic heart disease, this granuloma is known as the Ashkoff body. Very important. The granuloma is known as the Ashkoff body. Okay, and it has some special type of macrophages which are known as the Ashkoff cells, and they have a caterpillar-shaped nucleus in them. Okay. Finally, this Ashkoff body will be resolved and will be replaced by the fibrosis and the scar tissue. Okay, and this myocarditis is the most common cause of death because, like I told you, whenever you have any remodeling of the heart, like the myocarditis, like a dilation is happening, in case of myocarditis, you can have the arrhythmias, right? And the patient can die due to the arrhythmia. Okay, very important. Then for the pericarditis happen, you will have the pain with the friction rub. You will study that later again. The pericarditis part, don't worry about that. You will have the pain and you will have the friction rub, or a scratchy heart sound will be seen uh, on the auscultation of the heart. Okay, this is the pericarditis. So this is the myocarditis. This is a pancarditis in case of rheumatic heart disease. Okay. Same thing FA has described here, the Aniskov cells, the Aniskov bodies, the rod-like or the capillary this nucleus. This is the granuloma of the myocarditis in case of rheumatic heart disease. And this whole thing is known as the Aniskov body. And it has some caterpillar-shaped cells. If you try to zoom in, I think you can see that somewhere. They have a capillary, this caterpillar-shaped nucleus, and these are the Aniskov cells. Okay, like this. Okay, these are the Aniskov cells. You will see. And why this happened? Because of the M protein cross-reactivity. It is a type 2 hypersensitivity reaction. Okay, while the PSGN is a type 3 hypersensitivity reaction. Treatment, whenever you suspect a case of pharyngitis, okay, with the Streptococcus pyogenes or any case of pharyngitis, whenever you encounter, you need to immediately give the patient penicillins as soon as possible to prevent this complication, right? Now, outside the heart, patient can have a joint problems like the migratory polyarthritis. Okay, patient can have a nodules on the skin, subcutaneous nodules. Okay, patient can have a erythema marginatum. Okay, which is kind of a ring-shaped rash. Okay, patient can have a Sydenham chorea, very important. Patient can have a Sydenham chorea, okay, in which the patient have this jerky movement of the hands and the feet, purposeless, and they will describe it like a purposeless, non-purposeless, non-purpose or the purposeless jerky movement of the hands. Okay, it can be happen within a year after the this pharyngitis episode. So sometimes the patient do not have any history of the heart related issues, but it just it would be just an infant, a children or a child, right? And he's having a history of this non-purpose jerky movements, okay, and some history of pharyngeal infection. That's how you immediately know that it is a case of rheumatic heart disease. Okay, very important. And what are these subcutaneous nodules in the skin known as? Anyone knows? Anyone?
John?
Yeah?
John's nodule?
No, that's in the endocarditis.
Oh,
Right? No? Erythema nodosum. Remember? Erythema nodosum, which you have a very painful lesions on the shin of the leg, right? These are the painful skin nodules, reddish, painful skin nodules you will see. Okay? These are the erythema nodosum. Okay? You can write it down. And in the previous lectures, in the microbiology, we have discussed similar thing, the nodules in the skin, the erythema nodosum. Can anyone tell me where in the microbiology? Anyone? Erythema nodosum in microbiology. We have discussed this. Any fungi? Yeah.
In
Oxidomycosis.
coccidioidomycosis.
Exactly. Okay. Remember the causes. At the end, when we discuss a dermatology, we will discuss all the causes of this erythema nodosum. So, please remember these things. Okay. Very important. So because of this myocarditis, the patient is having a biventricular and biatrial dilation and the and the systolic heart failure. So you will get the hypotension, okay, loss of cardiac output. Patient will have a orthopnea, dyspnea, and then the death can occur because of the tachycardia. And that's why I think FA has also mentioned this fact that the most common cause of death is the pancarditis in case of rheumatic heart fever. No, they didn't mention that. So yeah, the acute morbidity is due to the pancarditis. Okay, very important. Okay, so any doubt on this rheumatic heart disease?
No.
Then comes the syphilic heart disease that occurs only in the tertiary syphilis. The characteristic feature of the tertiary syphilis is the involvement of the heart. Okay, you will get the endarteritis, which is the inflammation of the vasa vasorum. Vasa vasorum supplies the aorta, right? So the blood supply to the aorta is lost. You will get the inflammation in the aorta. Okay, and because of that, you will get the the inflammation in the tunica media, and the tunica media contains the collagen and the elastin. Okay, elastin for the for this stretchability, and the collagen is for the strength, right? So the collagen is lost, strength is lost, elastin is lost, and because of the elastin, the vessels will become very dilated. Okay, aneurysm can happen, right? And rupture of the vessels can happen because of loss of collagen. Okay, so we have discussed that already in the thoracic aorta aneurysm, if you guys remember. One of the cause is a syphilis. Okay, and if the root dilation occur, it can also cause the aortic regurgitation, if you guys remember. Very important, it can lead to the aortic regurgitation. Okay, generally the aneurysm of the ascending aorta occurs. Very important. Okay, and it can lead to the tree bark like appearance of the aorta. You can remember this as kind of a pathognomonic thing, a buzzword. Okay, tree bark like appearance of the aorta you can get after the calcification. So this is a syphilitic heart disease. Okay, and can anyone tell me that all the symptoms of the syphilis, all these rashes, all the ulcers, every symptom that you are having in case of syphilis, why these symptoms are occurring?
Because of end arteritis.
Exactly. Step one will ask you this. So at any stage of the syphilis, when you do the biopsy of the lesion, at any lesion you can find the endarteritis. And because of this endarteritis, only you are having all of these symptoms. Okay, very important to remember. Any doubt?
No.
Now, then comes the pericarditis, which is the inflammation of the pericardium. As you can see, the pericardium here is become very thickened. Generally, it's a very thin membrane-like structure, okay? But at this case, as you can see, the pericardium has become very thickened because of the inflammation. This is the inflammation of pericardium, the pericarditis, okay? It generally present with the sharp pain, okay, that aggravated by the inspiration. Very important, a pain which increased with the inspiration. Okay, very important. So patients are generally unable to take the breath because of this pain, right? And another important thing that the pain is relieved by the sitting up and leaning forward. Okay, very important. The pain is generally relieved by sitting up and leaning forward. Okay, so whenever they try to, go over a mountain, they have to, lean forward for that. And at that time, the symptoms could be very much relieved. Okay, and they generally lean on the shopping carts, okay, to relieve the symptoms of it. Okay, and it is oftenly complicated by the pericardial infusion, because whenever there is a inflammation, there is always an increase the permeability of the of all the blood vessels, and as a result the effusion of the pericardium can occur. And if the effusion become too much, it can lead to the, tell me what disease it can lead to if the effusion become too much.
Cardiac tamponade.
Exactly, cardiac tamponade, very important. Okay, so these are symptoms: the sharp pain, and the pain is aggravated by the inspiration. Okay, decreased by leaning forward. Okay, and it is often complicated by the pericardial effusion. Now, what you will find on the auscultation is the friction rub. Very important, or a very scratchy heart sound. We generally describe it as a scratchy heart sound. Okay, when you do the ECG of the patient, what you will see is the widespread ST segment elevation. See, ST segment elevation is not happening onto one or two leads only, but all the leads, the lead V1 to V6 to AVF, AVR, AVL, every lead will be having this ST segment elevation. So a widespread ST segment elevation is a characteristic feature. Other feature is the PR depression. As you can see, generally after the P wave is over, there's a horizontal wave comes, right? Which is a PR wave. In this scenario, you have a PR wave depression like that. Okay, very important. So PR depression and ST segment elevation. Okay, causes most commonly, like we have discussed previously on the microbiology section, also in the virology section, we have discussed that Coxsackie viruses, okay, are the most common cause of acute pericarditis, right? So they can cause the acute pericarditis if Step 1 did not mention any specific cause for that, any hint for the specific cause, then you always considered it as a viral pericarditis. Okay, if they have not given you any specific history, then always consider it as a viral pericarditis. Other cases could be the tumors, sometimes the autoimmune conditions like the systemic lupus erythematosus, okay, rheumatoid arthritis, uremia, because of the because of this uremia, you have a widespread inflammation in your body, okay, and the inflammation of the pericardium can cause the pericarditis, of course, okay. Then after this MI, okay, you have the Dressler syndrome, if you guys remember, which is an autoimmune condition, right? In the acute MI, within 1 to 3 days, you have an inflammation because of these neutrophils, okay, against this necrotic tissue, right? And the post-infectious, sorry, the post-infection pericarditis can occur, okay. Other thing would be the radiation therapy. Because of radiation therapy, you can have a fibrosis there, you can have the inflammation, okay, it can lead to the pericarditis. Treatment are generally anti-inflammatory agents like the glucocorticoids, like the NSAIDs, like the colchicine, okay. And for the uremia cases, you need to do the dialysis. Very important. Okay. Any doubt on it?
No.
Then comes the myocarditis, which is an inflammation of the myocardium. We have discussed that previously in the rheumatic heart disease also, right? So it causes a global enlargement of the heart and the dilation of all the chambers. All 4 chambers will be dilated. You will having a heart failure with reduced ejection fraction, or I can say systolic heart failure. And it is a very common cause of sudden cardiac death in patients who are less than 40 years of age because of the ventricular tachycardia, of course. Because of pathological remodeling of heart is happening, it can lead to the ventricular tachycardia. Symptoms include the heart failure symptoms like the dyspnea. You will get the chest pain. Because it is an inflammation, the myocarditis, you will get the fever. You will get the arrhythmia, like we have discussed. Okay. Multiple causes are there, like the viral causes includes Coxsackie virus, adenovirus, parvovirus. Okay. And the lymphocytic infiltration in that area can cause the myocarditis. Parasitic causes like a trypanosoma cruzi, we have discussed, it can cause the apical dilation of the heart, right? Toxoplasma gondii can cause it. Bacterial causes includes a Borrelia, Mycoplasma, Corynebacterium diphtheriae. Remember that toxin of this bacteria, if it becomes systemic, it can go to the brain. It can cause the paralysis. If it go to the heart, it can cause the myocarditis, if you remember from the previous lectures. Okay. Toxins like the carbon monoxide and black widow venom, they can cause the myocarditis. Rheumatic fever, we have discussed, can cause it. Drugs like the doxorubicin, okay, and like a trastuzumab, they can cause a trastuzumab causes this dilation of heart without any inflammation, right? But like we have discussed, the doxorubicin can cause the dilation with the fibrosis, right? So myocarditis would be there. Cocaine can cause it by the vasospasm of the vessels. The blood supply would be lost, and as a result, you can get the inflammation there. Autoimmune conditions like the Kawasaki disease, like the SLE, like the sarcoidosis, like the polymyositis and the dermatomyositis, they all can cause the myocarditis. Okay. Complications include the sudden cardiac death because of the arrhythmias and the heart block, the dilated cardiomyopathy, heart failure, okay, and the formation of thrombi. Thrombus formation occur, which can become the embolus, can dislodge and can enter the systemic circulation, can cause a stroke, can cause the infarction in any area of the body, right? So, how will you know what is the cause, specific cause of this disease of the myocarditis? So, first thing would be look at the history of the patient. Okay, and second thing, if they give you the biopsy, then in case of sarcoidosis, there must be a granuloma, right? In case of polymyositis, dermatitis, there must be the lymphocytic infiltrate would be there, right? In case of a cocaine, there must be some neutrophils could be there. In case of rheumatic fever, you will get a granuloma, right? And similarly, in case of trypanosoma cruzi, you can even see the organism. If you remember what you will see in the trypanosoma cruzi when you do the
A
biopsy,
mastigotes. A
exactly,
mastigotes.
masticoids. Okay, please remember this. And for the viral, you will see the lymphocytic infiltrates again, right? So looking at the biopsy and looking at the history will be helpful for diagnosing the condition of the myocarditis, a specific cause, right? Any doubt?
No.
And now we have discussed so many type of chest pains, as it has, the myocarditis, the pericarditis, the rheumatic heart disease, the myocardial infarction. Okay, so whenever you encounter a case of a chest pain, how you can differentiate whether it is a this disease or this disease? Okay, so we discussed in what disease, what kind of chest pain you can experience. Okay, so in case of any coronary artery disease like the angina or like the myocardial infarction, the chest pain is generally a substernal burning type. Okay, and the patient generally is complain of squeezing chest pain or a chest heaviness. Okay, and the pain generally radiates to the jaw and to the arms. Okay, in case of this pericarditis, okay, you have the pain which worsens when lying flat and decreases while leaning forward. Okay, and this pain also radiates to the jaw and to the neck, shoulder and arm. Okay, and the pain is generally worsened with the inspiration. Okay, and similar pain you can experience in case of pulmonary edema or in case of a pneumothorax for say. Okay, you will have the respiratory distress, you will have the hypoxia, you will have the shortness of breath in this scenario, and again the pain will be increased with the inspiration. So see, pain is increasing with the inspiration in both the pericarditis and in the pneumonia and in the pulmonary edema. Okay, but in case of the in case of this edema, you will have the shortness of the breath also. In case of pneumonia, you have the pain which increases with the inspiration along with the fever and cough and the shortness of breath, of course. Okay, and this type of pain which increases with the inspiration, it is known as a pleuritic chest pain. Okay, very important because it involves the pleura of the lungs and it happens whenever you inspire. Okay, then the pain of the aortic dissection, it is kind of a tearing chest pain. Okay, and the tearing chest pain always radiates to the back of the patient. Okay, plus you have an unequal BP in the arms, very important, and the BP difference must be more than 10 mm of Hg. Okay, and the patient must be having a history of any hypertension sometimes or any other risk factors like we have discussed, like the Marfan syndrome or other diseases. Okay, for any GI pain, okay, like in case of GERD, you have a burning type pain. Okay, substernal burning would be there along with some abdominal pain, and pain generally increases at the time of night because in the night you have a high parasympathetic activity which causes the increased acid secretion in the GI, in the stomach, and that can worsen the pain. Okay, so for the esophageal pain or any GI pain like the GERD, in case you will have the pain which is worsened in the night. Okay, you have a dry cough. Okay, and you have a burning type of pain. Substernal burning would be there. It depends upon the ulcer you are talking about. If are you talking about the ulcers? Okay, so it is a different type of pain. If it's relieved by the food, then it must be duodenal ulcer. If it is not relieving by the food, and with the empty stomach, it kind of worsening. Sorry, with the empty stomach, it is okay. Then it must be the a proper GI ulcer. Okay, so depends upon the cause. Okay, very important, differentiate different type of pains. So please remember all these things we have discussed. If you have any musculoskeletal pain, then pain will be localized to a specific area only. Okay, whenever you change the position of your thorax, whenever you move, okay, whenever you inspire, the pain will occur at a specific location only on your chest wall, and whenever you palpate over that area, you can feel the pain over that area only. So even on the chest inspection and or symptom wise also, okay, you will get the pain at a very localized area only, and that's how you know that it could be a pain with the musculoskeletal problems, right? For like say the costochondral syndrome, you will study later in the MSK chapter, the costochondral syndrome. Okay, so that's how you can differentiate between different pains. Is that okay?
In real life, chest pain related to acute coronary syndrome, the hallmark mainly is patient would say elephant sitting on the chest.
Yeah, if something if someone sitting on their chest, the chest heaviness, that's what I said, right? Chest heaviness or a squeezing type of pain, they will say. Okay, I think this page is clear. Yes.
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 Okay, then we study the vasculitis, which is the inflammation of the vessels. We have discussed the inflammation of the heart. We have discussed the endocardium inflammation. We have discussed the pericardium inflammation. We have discussed the myocardium inflammation. Okay, one more thing we have forgot to discuss is the constructive pericarditis. We have discussed the acute pericarditis, but in case of a chronic inflammation of the pericardium, you can have a constructive pericarditis. Okay, that happens because of a repeated acute episodes of the pericarditis. Okay, or sometimes by the tuberculosis, which is a chronic disease, you guys know. Okay, sometimes by the radiation. Okay, and sometimes after the cardiac surgery, you can have the inflammation, and the inflammation is kind of very much asymptomatic type and a very prolonged one. Okay, and if you guys remember, whenever you have a very chronic inflammation, the damage and the repairing will be occur side by side, right? And ultimately you will get the calcification in that area. Okay, so the hallmark feature of the constructive pericarditis is the calcification around the heart, the area that you are seeing, which is kind of very dull initially. Okay, in case of a constructive pericarditis, this area will be very enhanced because of the calcium deposits that you will see in the constructive pericarditis. Okay, you will have the thickening and the calcification of the pericardium. Okay, so again, the patient will present you with the dyspnea, with the edema because of the symptoms would be exactly similar to that of restrictive heart disease. You will get a biventricular heart failure. You will get the dilation of the atria bilaterally. Okay, so every symptom or everything that you experience in the restricted heart disease, you will see exactly same thing in the constructive pericarditis. Very important. So whenever you encounter a case of constructive pericarditis and you don't know what could be the answer, just think about the restricted heart disease. Both of these things are kind of very much similar. Okay, in both of them you will get a rapid Y descent. Okay, you will get a small sign in both the restricted heart disease as well as constructive pericarditis. Very important. Okay, so constructive pericarditis and the restricted cardiomyopathy, they both share very common features, and that's why it is very hard to distinguish between them. Okay, so whenever in the exam they ask you anything about the constructive pericarditis, just think about the restricted heart disease that we have discussed. Okay, and a rapid X descent for the cardiac tamponade and a rapid Y descent for the constructive pericarditis. That's how you can differentiate between the cardiac tamponade and the constructive pericarditis. If that don't give you much hints, okay, very important. And please remember, Kussmaul sign is not seen in the cardiac tamponade. Jugular vein distension is seen in the cardiac tamponade, right? But in case of constructive pericarditis and the restricted heart disease, you will see the Kussmaul sign along with the jugular vein distension. Okay, very important. Now the vasculitis, which is the inflammation of the blood vessels. Okay, first we talk about some large vessels. Okay, like your like the carotid arteries. Okay, and the arteries are like the temporal arteries. Okay, then we'll go for the medium vessels, which supplying your organs, like the like the renal arteries and arteries of the lung and other areas. Then we discussed about the smaller vessels, which are even supplying your skin. Okay, so let's discuss all of them one by one. So first is the giant cell temporal arteritis. Please remember this whole name, giant cell temporal arteritis. Okay, this is the inflammation of the temporal artery. Very important. This is the inflammation of the temporal artery. So it affects every region which is supplied by the temporal arteries, like your jaw, like your eye. Okay. So, and your head, and the area which is supplied by the temporal arteries, like the head, would be have a unilateral headache because the unilateral temporal arteries involved. Okay, so you will get the unilateral headache. You will get a jaw claudication because of the inflammation. The lumen of the vessel will become very narrow. The blood supply to the area will be lost. So whenever you try to use that area, like in case of any chewing, okay, you will get a jaw claudication. Okay, because of the involvement of the ophthalmic artery, you can have an irreversible blinding, and that's why to prevent the blinding, whenever you suspect a patient, this giant cell arteritis, without waiting for the lab results, you need to give them corticosteroids as soon as possible to prevent this blinding. Okay, Along with that, the patient will also have a polymyalgia rheumatica, in which you have a proximal muscle pain. See, not the weakness, but the pain you have in the proximal muscle groups, like the shoulder, okay, like the hips. So patient generally complains of pain whenever they try to get up from the chair, or whenever they try to do the overhead movements like combing. Okay, so they generally complains of the pain in the shoulders and in the proximal arms. Very important. So pain along with the jaw pain, headache, and a blurring of the vision. You will always suspect the giant cell arteritis. And please remember that it is a disease which only affect people more than 50 years of age. If you ever encounter a question in which the patient has a age of less than 50 years or 40 years, that means it cannot be a temporal arteritis. Okay, the patient must be above 50 years of age. Very important. And because it is an inflammation and it involving your systemic circulation, okay, you will get the fever, you will get the fatigue, you will get the malaise, you will get the weight loss along with all these things. Okay, first test, which is a sensitive one, you will run is the ESR. What you will find is the increased ESR because it is a acute phase reactant. Okay, you will see in the uh, in case of inflammations the high ESR count. Very important. Then after you're suspecting you're suspecting vasculitis and you're having a high ESR count, and you're suspecting this might be a case of temporal arteritis, you will do the biopsy of the patient. And on the biopsy, because it is involving a giant cells, okay, multiple giant cells, you will have the granuloma thing also. Okay, so it is a granulomatous inflammation. Very important. Okay, multiple areas in the blood vessels would be there which are having these granulomas. Okay, then some areas will come which are absolutely normals. Okay, then some areas with the inflammation, then normal area, then again inflammation area. Okay, so alternative areas with the inflammation would be present. Okay, and high dose of corticosteroids must be given without waiting for the lab results or the biopsy reports. Okay, to prevent the blindness. Or it affects the branches of the carotid arteries, most commonly the temporal artery. Okay, and because the interleukin 6 is kind of involved, so increase in the interleukin 6 synthesis or the secretion, you will have an increased severity of the disease. Okay, very important. Then comes the Takayasu arteritis. And Takayasu arteritis has symptoms just like the temporal arteritis. Okay, it is very hard to differentiate between the two diseases, but the only thing that will help you is the age of the patient. Okay, if the age is below 40 years and symptoms are exactly just like the temporal arteritis, you can without any second thought, you can take the answer Takayasu arteritis if the patient is below 50 or below 40. Okay, in this disease you are having inflammation at the at the branching of the arteries. At the branching sites you will have a granulomatous thickening, and as a result the blood supply to the particular area would be lost. You can have an unequal BP in the arms, just like that in case of this aortic dissection. You can have the unequal BP in the arms. You will have the unequal BP in the upper extremities and the lower extremities. And because upper extremities are involved much more than the lower extremities, so generally you have a low upper extremity pressure and a very high low extremity pressure, and that's why it is known as the pulseless disease. Okay, you will get the fever, you will get the night sweats, you will get the ocular disturbances, joint pain, muscle pain, skin nodules, anything. Symptoms are mostly similar to the giant cell arteritis. Okay, and age will help you differentiate between the two. Okay, and it generally involves the proximal great vessels like the subclavian artery, the brachiocephalic trunk. Okay, they can be affected. So, any doubt on these two diseases?
No.
Okay. Then we discuss the medium vessel vasculitis, and the first one is the Berger's disease or the thromboangiitis obliterans. Okay, it is not the inflammation of the vessel wall, okay, but actually a thrombus is formed inside the vessel, okay, which is an inflammatory thrombus, and it and because of the formation of this thrombus, it is kind of blocking the blood supply to that particular organ or to that particular area. Okay, so it is because of the formation of an inflammatory thrombus. Okay, not the inflammation of the vessel wall. Very important. Generally, it is seen in the heavy smokers only, And because of the thrombosis formation, the blood supply to the particular area would be lost. So you will get the intermittent claudication. Whenever the patient try to do the exercise or try to do the walk, he can experience the pain. Okay. If the fingers are involved, then gangrene can happen because of loss of blood supply. Okay. It could lead to the auto amputation of the digits. Okay. Patient can also have a superficial nodular phlebitis. Okay. Which is which is a thrombus formation in the very superficial veins. Okay. So patient generally have a very erythematous area, very tender area. Okay. Along the vein side. Okay. Very important to know that superficial nodular thrombophlebitis. Inflammatory thrombi are formed inside the vein. So patient will have a very erythematous tender area along the veins. Okay. And the Raynaud's phenomena is also present. Whenever the patient place the fingers in cold, the fingers become very pale. Okay. And when they again brought in back into the warmth, they will become first white, then yellow, and then red. This is a Raynaud's phenomenon. Why? Because the blood supply to that particular area is lost now. And in cold, you guys know when the sympathetic system activated in the cold, it will cause a peripheral vasoconstriction, right? So already there is a thrombus, and above the thrombus, you are having a vasoconstriction. So that can further cause the Raynaud's phenomena. Okay. Treatment is just a smoking cessation. Very important. Now, along with the formation of this inflammatory thrombi, okay, patient will also have a inflammation in the vein as well as the nerves. Okay, you have a formation of inflammatory thrombi in the vein. Along with the vein, you also have a nerve involvement. Okay, so patient can also get the sensory loss sometimes, or the patient can even become paralysis. Very important. Okay. And most commonly, the symptoms will be present on the fingers. Okay, so patient, because of the ischemia, will get the ulcerations at the fingertip. Okay, depressions, dips will be present at the very fingertips of the patient. Very important. This is the most common symptom which occurs in case of this thromboangiitis obliterans, which is the ulcerations at the fingertip. Because the watershed area is the fingertip, right? It will be supplied at last by the arteries. So first ischemic area. Any doubt on the Burgess disease? Any doubt?
No.
No.
Okay, then comes the Kawasaki disease. Kawasaki disease generally affect only children which are less than 4 years of age. First thing, the children must be less than 4 years of age, and along with the 4 years, the patient must be having a history of fever more than 5 days. This is very important. Whenever they give you a history of Kawasaki disease, they will always mention the patient is having a fever more than 5 days, 6, 7, or 8 sometimes. Only then you will suspect the case of Kawasaki disease. Now, along with the fever, the patient generally has 4 of the following symptoms. Okay, which is the bilateral non-exudative conjunctivitis, because I told you these are the medium vessel inflammation. Okay, and they're supplying the organs, so multiple organs are affected. Okay, in case of eye, you will have the non-exudative conjunctivitis. Okay, you will have the sore throat, just like the pharyngitis. Okay, and when you do the examination, the mouth and the oral examination, what you can see is the redness of the palatine mucosa. Okay, you will have the cervical lymphadenopathy. Okay, and that strawberry tongue. If anyone remember where you have studied this strawberry tongue,
Scarlet
tongue with that
fever.
reddish dots. Yeah, say it again.
Scarlet fever. Scarlet.
Scarlet fever, yes, very important. Scarlet fever. Okay, so now you can see the disease is kind of very much resembling to the scarlet fever, right? Because in both the scenarios, you are having a sore throat, you are having a rash, you are having a lymphadenopathy, you are having a strawberry tongue. Okay, so the only thing that you can use to distinguish between the two is the fever. First, the fever is more than 5 days. Second thing is the conjunctivitis, which is not exudative type, because the bacterial conjunctivitis is always a exudative type. Okay, this is just a redness of the eye will be there. Okay, and the extremities changes are important. You will get the rash all over the body. just like this scarlet fever. But along with the rash, you will have the erythema over the palms and soles, as well as the edema of the hands and feet. So patient generally complains of a swelling in the hands and in the feet. Okay, plus a rash, which is kind of a very reddish or the erythematous rash that start on the extremities and then go to the trunk. Okay, it can mimic the streptococcus infection. However, edema won't be there, conjunctivitis won't be there, and a persistent high grade fever is a very characteristic thing in the Kawasaki disease. Fever more than 5 days is must, along with 4 of the following symptoms should be present. So whenever you encounter children who is having a fever plus any 4 symptoms, that means it is a case of Kawasaki disease without any doubt. Okay. Any doubt up to here?
No.
Then what are the complications? Complications are the coronary artery aneurysms. Because of the inflammation, the vessel wall become very weak. They will be dilated. Okay, they can rupture and they can cause the death, thrombosis, myocardial infarction. Treatment, aspirin, very important. The only disease in which you can give aspirin to a children is the Kawasaki disease. Very important. Then comes the polyarteritis nodosa, which is a type 3 hypersensitivity reaction because the immune complexes will be deposited inside the vessels in the walls, and that can cause the inflammation. Very important, you will get the fibrinoid necrosis and the transmural inflammation in case of polyarteritis nodosa. Okay, both the tunica, the tunica intima, the tunica media, and the tunica externa, all these 3 layers will be inflamed in case of polyarteritis nodosa, and you will get the fibrinoid necrosis. If you guys remember the histology of the fibrinoid necrosis, it is very important. They will give you the histology. Okay, they will show you these pinkish vessels, right? Just give me a second. Okay, they will give a very pinkish, walls of the vessels, and that's how you can see that it is a fibrinoid necrosis, diffuse pink and thickened wall, right? So they can affect any organ. Okay, in the GI tract, they can cause abdominal pain because of the ischemia, of course. Melena can happen, which is the very bloody stools. Okay, bowel perforation can happen. Hypertension can happen. Okay, because when the blood supply to the kidneys are compromised, the RAS will be activated. You will get the hypertension. Neurological dysfunction can happen if the if the vessel supplying the brain will become damaged. Okay, renal damage can occur, so you will get a high uh, this creatine level, low GFR. You will get a high LFT, high RST, right? And it is a necrotizing inflammation with multi-system involvement. Okay, and all of the symptoms that you are getting in case of polyarteritis nodosa, it is because of 2 things. One is the lumen narrowing, which can cause ischemia, and second thing is the rupture of the vessel, which is causing the hemorrhage type thing. Okay, 2 things: ischemia and hemorrhage. Because of this ischemia and hemorrhage or the bleeding, you are having all of these symptoms. Okay, now because of the inflammation, like we have discussed, we have the tunica media, which contains the collagen and the elastin. Okay, they will both become destroyed, and as a result, the vessels will become very weak. Okay, and they will become very dilated. So aneurysms can form, right? Because of the type 3 hypersensitivity reaction, the immune complexes will be depositing in the vessel walls that can thicken the vessel walls at some areas. Okay, and can cause the narrowation. So as you can see, at some places you have the dilation, some places you have the narrowing, then dilation, then this narrowing. So it is kind of a beads on a string structure, as you can see here, right? This is what you get in the polyarteritis nodosa. Very important. Okay, and sorry, string of pulse, not a beads on a string, but a string of pulse. It doesn't matter, by the way. They won't give you this string of pulse anywhere, right? So at some places you're having the constriction, at some places you're having the aneurysm or the dilation. Okay, that's you could easily see on the angiography of the patient. And when you do the biopsy, you will see the inflammation and the necrosis. Okay, and please remember one thing, that the pulmonary arteries are not involved. So you won't get any pulmonary symptoms, no dyspnea, no shortness of breath, no orthopnea, nothing, nada. But every other organ could be involved. So it is kind of very hard, to kind of differentiate it with other diseases, other infections or other causes. Okay, so they must give you some kind of a hint, like some kind of a disfibrillar necrosis they will tell you, or they can give you a histology. They can tell you something about the string of pulse appearance. Okay, they can tell you something about the aneurysm formations. That's how you know that this could be a case of polyarteritis nodosa. And 30% of cases are associated with the hepatitis B. Very important. Step 1 will ask you this: what virus can cause the polyarteritis nodosa? This is the hepatitis B virus. Okay, and just like any other disease, any other vasculitis, you will get a systemic symptoms like fever, weight loss, okay, and night sweats, headache, something like that. Okay, any doubt on the polyarteritis nodosa?
No.
Then comes a small vessel vasculitis. Okay, first is the Basser syndrome, which is a triad of the aphthous ulcer, which is the oral ulcers, painful oral lesions. Okay, then the genital ulcers, and third thing is the uveitis. Very important. Whenever you get a triad of the aphthous ulcers, genital ulcers, which are around the anus, scrotum, or vulva, and the uveitis, okay, you will having a Basser syndrome. Okay, it is generally occurred by the herpes simplex virus or the parvovirus. Okay, and it is associated with the HLA-B51. This is very important to know. They will ask you this. It is because of HLA-B51, and because it is an immune complex vasculitis, that means it is a type 3 hypersensitivity reaction. Immune complexes will be settled on the small vessels, okay, vessels which are supplying your oral areas, genital areas, and the eye, and they can cause the aphthous ulcer, genital ulcers, and uveitis. Generally occur whenever the patient has a herpes simplex virus infection or the parvovirus infection, and only in the individuals which are HLA-B51 positive. Okay. Then comes the cutaneous small vessel vasculitis. As the name suggests, it would be a vasculitis affecting the cutaneous vessels. So only mostly the skin symptoms happen, right? And because because of the inflammations, the vessels are in the subcutaneous region, they become very weak, they will rupture, and as a result the blood will be start getting out of the vessels, hemorrhage like thing. So you will get the this palpable purpura, this palpable purpura. It is not a tube purpura. Okay, the tube purpura occurred because of thrombocytopenia. Okay, when the thrombus when the platelets are become dysfunctional or they become less in the number, then you can get the purpura. Okay, but it is a palpable. Why? Because it is kind of a raised. Okay, like in case of a normal purpura, this is a skin level, let's say. Okay, and a normal purpura would be like some kind of very flat rash. Okay, you cannot palpate it, but a palpable purpura is like a raised lesion over the skin. Okay, you can easily feel that with your hands. You can palpate it with your hands. This is a palpable purpura, and happens why? Because the blood is getting out of the vessels, accumulating in your skin, right? That will cause the palpable purpura. Very important. Okay, and this leakage of the blood will happen mostly on those areas which are dependent in your body, dependent part, like when you're standing. Okay, the most dependent part on your body is your legs, right? And when you are sleeping, the most dependent part would be your back. Okay, so these rashes, the palpable purpura, will generally happen in the leg part and in the back part, on the buttocks. Okay, this is very important thing. So that's all thing you get in case of cutaneous small vessel vasculitis. Okay, it is a leukocytoclastic. Because of the depletion of the immune complexes, you will have the neutrophils, which are the leukocytes, and that's why the name leukocytoclastic vasculitis. Okay, it generally occur after giving a patient drug. Okay, because of the drug, the immune complexes will form, and that can cause the inflammation. So drugs include all the beta-lactam drugs like the penicillins, cephalosporins. Okay, you can get in with the phenytoin, with the allopurinol, Okay, sometimes with the infection like hepatitis C, very important. Hepatitis B can cause the polyarteritis nodosa. Hepatitis C can cause the cutaneous small vessel vasculitis. Uh, Although the first aid is saying that no visceral involvement is seen, but you can get the visceral involvement also. Okay, at a very late stages, at a very high stages, you can even get a visceral involvement. Okay, I've read the paper, and in the paper they have mentioned this, that you can get this symptoms also of the liver involvement and the kidney involvement and other areas also. Okay, but usually in the step 1 you will get only the skin symptoms. Okay, any doubt on it? Any doubt?
No.
Okay, so now we discuss about the other vasculitis, small vessel main. Okay, and the first is the eosinophilic granulomatosis with polyangiitis. As the name suggests, it is because of the eosinophilia, eosinophils mediated. Okay, and granulomas are there, and that's why the name granulomatosis. So eosinophilic granulomatosis with polyangiitis, also known as the Churg-Strauss disease. Okay, you will have the involvement of the lungs, you will have the involvement of the kidney, you will have the involvement of the nerves. Okay, and other areas like heart and the GI tract sometimes can they also be involved. Okay, in case of lungs, you will get the asthma. Very important. Whenever you get a patient with a history of asthma, and now he is having any other organ involvement like the kidneys, okay, or like they have any sensory symptoms or the nerve symptoms, that means it must be a case of eosinophilic granulomatosis with polyangiitis. First thing would be the asthma. Second thing would be the rhinosinusitis. You will have the facial pain and the nasal discharge. Okay, the patient will also have the skin nodules because the blood supply, because the blood vessels are also supplying the skin. You will get the purpura also. Okay, just like any other disease. You will get the neuropathy because of involvement of the nerves. The blood vessels which are supplying the nerves, they will become inflamed. That can cause the ischemia and the neuropathy. Okay, so wrist drop, foot drop would be there. Sensory loss would be there. Heart involvement can occur. GI involvement can occur. Kidney involvement is very common. You will get the pauci-immune glomerulonephritis. Very important. You will get the pauci-immune glomerulonephritis. You will get the oligouria, hematuria. Okay, and you will see the granuloma formations, and it is a necrotizing vasculitis. Very important. Okay, in the patient body, you will get the eosinophilia, high eosinophil counts. Even when you do the biopsy of the organ, you can find the eosinophils there along with the granulomas. Okay, they will ask you about these antibodies. It is a myeloperoxidase, ANCA, or also known as the p-ANCA. Okay, so MPO or the p-ANCA would be there in case of Churg-Strauss plus a high IgE level. Very important. Okay. Then comes the granulomatosis with polyangiitis. So it is not eosinophilic. You will have the granuloma involvement. You will have the multiple arteries involvement. Okay. So you will have the classical triad of involvement of the upper respiratory tract, involvement of lungs, and involvement of kidney. Remember 3 things: involvement of upper respiratory tract, which includes your sinuses, okay, and the pharynx part, involvement of lung, okay, and the involvement of kidney. For the involvement of your upper respiratory tract, the most common symptom is the involvement of upper respiratory tract. Even the 95% of cases has this. So patient will have the nasal perforation sometimes because the blood supply to the nasal septum would be lost. Just like the cocaine, if you guys remember, you can get the nasal septum perforation. You will get the sinusitis. You will get the facial pain and the nasal discharge because of it. You will get the recurrent episodes of otitis media or the mastocytitis. Okay. For the lower respiratory involvement, you will get the hemoptysis, cough, dyspnea. Remember, it is a kind of necrotizing vasculitis. You will get the necrosis in the lungs, just like the lungs abscess, you will see. Okay, you will get the focal necrotizing vasculitis along with the necrotizing granulomas in the lung. So whenever you do the patient X-ray or MRI, what you will see is a cavitary lesion because of this abscess formation. You will see the cavity formation in case of this granulomatosis with polyangiitis, because it is a necrotizing vasculitis. Okay. Then for the renal involvement, you can get the post-immune glomerulonephritis. Okay, you will get the hematuria, you will get the red blood cast, you will get the oliguria. Okay, you will get the high creatinine level, you will get the crescents. Okay. For the lab tests, you can do the anti-PR3 or the C-ANCA. Okay, so remember C-ANCA for the glomerulonephritis with polyangiitis. Okay, and it is the anti-protease 3 ANCA. Okay. On the chest X-ray, you can see the large nodular densities or sometimes the cavity lesions. Nodular densities because of the granuloma formations, and cavity lesions because of the granuloma formations, and which causes a necrosis of the area. Okay. Treatment, again, because it is kind of autoimmune, you will give the patient glucocorticoids. Any doubt in both diseases?
No.
Then comes the immunoglobulin A vasculitis, which happens shortly after any kind of a mucosal tract disease, like any viral disease or any bacterial disease that causes the infection of the mucosal tract, either the GI tract or the respiratory tract. Okay, it can lead to the formation of IgA antibodies because they line your mucosal tracts, right? So IgA antibodies, if you guys remember from the immunology sections, they do not form any they do not fixes the complements, right? They can form the immune complexes, but they do not fixes the complements, right? But in this scenario, in the immunoglobulin A vasculitis, at a small amount, they can fix the complements also, very important. It is seen that they're fixing the complements in case of IgA vasculitis. Okay, so you will get a henoxylin purpura, which is not a very specific for it. In every disease that we have studied in the small vessel vasculitis, you can get the henoxylin purpura. Okay, you will get the upper, it is generally occur shortly after the upper respiratory tract illness or a GI illness within 5 days. Okay, it will be present itself within 5 days, very important. So it would be a patient having a pneumonia or having a diarrheal episode, and or any pharyngitis episode, and within 5 days of that episode, or even sometimes along with the pharyngitis, he started having these symptoms. Okay, please remember the classical traits for the skin. You will get the purpura, which is a palpable type, which we already studied. In the joints, you will get the multiple joint pains. Okay. Third will be the GI involvement. You will get the abdominal pain. Okay. And you can even get the interoception. So it would be a very acute type abdominal pain. Okay. And fourth thing is the renal involvement. So one thing is rash. Second is the joint. Third is the abdomen. And fourth is the renal. These four organs, if they're involved along with this infection history, that means it is a IgA vasculitis. Okay, you will get a very the bloody stools. This is very important. You will get a bloody diarrhea and the hematomasses. Okay, very important to know. And multiple joints would be affected. Okay, and these are all diseases are self-limiting. It will be happen second to the immune complex formation. That's why our type 3 hypersensitivity reaction. You won't get to see any granuloma formation in it. Okay. And along with this, you can have an involvement of kidney, which is IgA nephropathy. Okay. Treatment would be the corticosteroids and the supportive treatment only. Then comes the microscopic polyangiitis. Okay. Which is, it has the involvement of the lungs and the kidneys only. Okay. It is similar to that of granulomatosis with polyangiitis, but this thing has the involvement of the upper respiratory tract. In case of microscopic polyangiitis, you have similar conditions, you have similar symptoms, but no upper respiratory tract, no sinus involvement, no pharyngitis. Okay. In the lungs, they have this granuloma, in the lungs, they do not have any granuloma formations, but they do have the necrosis. So you will get the cavity lesions in them too. In the kidneys, you will get the post-immune, the glomerulonephritis. In the skin, you can get the palpable purpura. Okay, so all of these things are kind of non-specific type. Okay, very important. Then on the antibodies, these are very important. When you run the lab test, you can get the MPO ANCA positive or the P ANCA. So MPO ANCA for the microscopic polyangiitis, you can remember it like that. MPO for the microscopic polyangiitis. Although it is for the myeloperoxidase, but this is a easy way to learn. Okay, MPO, P ANCA. Okay, these are for the microscopic polyangiitis as well as the eosinophilic dermatosis with polyangiitis. And the NTPR3 or the C ANCA is for the granulomatosis with polyangiitis only. Okay, very important. Then comes the mixed cryoglobulinemia, which is happened just after the hepatitis C virus infection. You will get the skin rash, you will get the weakness, you will get the joint pains. Okay, you will get the peripheral neuropathies, you will get the glomerulonephritis also. Okay, and the all of these things are kind of non-specific. They won't help you in reaching to a specific cause. So the important thing would be the IgG and IgM immune complexes. Okay, and all of these immune complexes, they precipitate in the cold. This is very important. A patient with a history of this hepatitis C virus infection, later on he is having some kind of a disease which precipitates the immune complexes in the cold. Okay, and a positive rheumatoid factor. Okay, what is a rheumatoid factor? Anyone remember?
It's an IgM antibody against Fc portion of IgG.
Exactly, and it is seen in the rheumatoid arthritis. Okay, so you will also get a positive rheumatic factor in case of mixed cryoglobulinemia, and that's why the FA mentioned that this rheumatoid factor is not very much specific for the rheumatoid arthritis. It is a sensitive but not specific one. Okay, so what is the specific test for the rheumatoid arthritis?
Anti-CCP antibodies.
Exactly, anti-secretoline antibody or CCP, right? Very important to note. So that would be all about the vasculitis. Okay, any doubts so far?
No.
Okay. And this is about the arterial insufficiency. Whenever you have a blockage in the artery, what symptoms you can expect? First thing is the intermittent claudication, which is because of the ischemia. You will get the muscle pain whenever you try to exercise. Okay, at the tip of the fingers, you can get the ulcers because these are the watershed regions. Okay, you will get a small fingertip ulcers. You will get a thick, very brittle nails. Okay, you will get the gangrene. Okay, you can get a very cold skin because the blood supply is not there, so you can get the cold clammy skin. Okay, you will get the hair loss over the area because the follicles, they won't be getting any enough oxygen, so they will die. Hair loss occurs. Peripheral pulse is very important. They will become very weak because the blood is not there, arteries are blocked. Okay, so whenever you think about any arterial blockage, any peripheral blockage, you will always think about these symptoms. Okay, this can be happen after the atherosclerosis. It can be happened after the vasculitis. In case of a venous insufficiency, the blood is already there, but it just cannot be drained by the these veins. Okay, if you guys remember, the veins has the valves which prevent the backflow of the blood. Okay, but in case if you're having a history of very prolonged standing, or you're a pregnant, okay, or sometimes if you're having a history of any obesity, like in that case, the veins become very dilated and tortuous, and the valves become very insufficient. So because of this venous valve insufficiency, the backflow of the blood will occur, and as a result, the blood will be start accumulating in the lower part or the dependent part of the bodies, like your legs. Okay, so because you're already having the blood, you will have a warm skin over the area. You will have a very large superficial ulcer. In case of arterial damage, you will have a very small deep ulcer. In case of this venous deficiency, you will have the large ulcer. Okay, with the some kind of a extruate type thing also. Because the blood is already there, you will have the bronze skin because of the hemosiderin and the iron. Okay, you have the brownish and depigmentation of the skin. You will have the edema because all the blood, all the fluid from the veins, they started leaking out. That can cause the edema. You will have the warmth over the area because the blood was already there. Okay, and yeah, that would be all about the venous insufficiency. It has happened because of the varicose vein. You can even see the tortuous vein from the skin just by your eyes. Okay, very important. Risk factors include the obesity, pregnancy, prolonged standing, or any damaged valve due to any deep vein thrombosis. Is that okay up to here? Yeah.
Yes.
Yes.
Okay. Then we discuss about the cardiac tumors, and all of these tumors are kind of very rare. Why? Because you guys know that most commonly tumors affect only those tissues which have a regenerative potential, or they have a cells which are rapidly dividing, right? But the muscle cells, they are what kind of cells?
Permanent type of
Permanent.
cell.
Exactly, permanent type of cells. That's why these tumors are kind of very much rare. Okay, first one is the myxomas, which are the most common tumor in case of any cardiac tumor. Okay, most common primary cardiac tumor in the adults, and 90% of the times they happen in the atrium and in the left atrium, most importantly. And in the left atrium, they can block the mitral valve, and as a result, it can mimic the symptoms of the mitral stenosis. Very important. You will encounter a patient who is having a history of mitral stenosis, but in actually he's having the myxoma, not the mitral stenosis. Okay. This tumor has a very, on the gross examination, the tumor has a very gelatinous mass. Okay, and when you do the biopsy of the tumor, what you will see is some mucopolysaccharide as a ground substance in the background. You will see the mucopolysaccharide or any amorphous, substance in the background, and you have the scattered myxoma cells, kind of a bluish appearance of these cells would be seen. These are the myxoma cells in the mucopolysaccharide. It is a gelatinous mass. Step 1 will describe this tumor as a very gelatinous mass, and on the biopsy they will tell you that the tumor is having a very amorphous type extracellular substance. Okay, 90% of the times they originate in the left atrium. That's why the patient, just like any other cancer, have some non-specific symptoms like fever, fatigue, weight loss. Okay, and if the tumor become dislodged, then from the left atrium it can go to the left ventricle. From there, it can enter the systemic circulation. It can go to your brain, can cause a stroke. It can go to your kidney, can cause the infarction. It can go to other organ, can cause the infarction there, right? So it could be a patient who is having a history of a stroke or a paralysis or any flank pain, like in case of renal infarction. And when you do the biopsy of the patient for this lesion, they will tell you that the patient is having actually some kind of gelatinous mass as the embolus. So that's how you know that this must be a case of myxoma. Right? Very important. And they have a kind of special type of obstruction. When you are sitting, the obstruction become increased, and when you are laying down, okay, then obstruction become very less or relieved. Okay, so generally the dyspnea occurs at the time of sitting. Okay, and the dyspnea will be relieved with the sleeping. Okay, this is also very important. And they will release interleukin 6 just like any other tumor, and they will cause the constitutional symptoms. Okay, you will have the gelatinous mass and the myxoma cells, and yeah, that would be everything about this tumor. Please remember the mitral stenosis is very important. Every symptom of the mitral stenosis, like the heart failure type, dilation of the chamber, and this Ortner syndrome, dysphagia, hoarseness. Okay, the lungs involvement would be there, right? So yeah, that would be all about it. Any doubt on the myxoma?
No.
Okay. Then comes rhabdomyoma, which are the most frequent, the cardiac muscle tumor in case of children. Okay, it is almost every time a case of infant or a children, not the infant, but the children less than 10 years of age, I think. Okay, on the histology, you will see the hematomatous growth. And it is associated with the tuberous sclerosis. This is very important. It is associated with the tuberous sclerosis. Okay, and because of this hematomatous growth, it can block your valves. Okay, so it can mimic the mitral stenosis. It can mimic the aortic stenosis. It can mimic anything like the stenosis. Okay, either it can cause a left ventricular outflow tract obstruction, like the mitral stenosis. The patient will having a symptoms. When you do the biopsy, will see the this hematomatous growth from the valves, and that's how you know this could be a case of rhabdomyoma. Then comes the Kussmaul sign. Kussmaul sign, whenever you have the inspiration, whenever you do the inspiration, what's going to happen? The pressure inside the thoracic cavity will be dropped. And as a result, you will see the, the drainage of the blood back into the right atrium. So in that case, the jugular veins must be de-distended, must be compressed, right? Must be kind of non-distended. But in case of Kussmaul sign, instead of a normal decrease in the jugular venous pressure, you have an increased in the pressure with the inspiration. Okay, and because of that, you will have the jugular vein distension even with the inspiration. This is known as the Kussmaul sign. Please remember the causes. We have discussed that. The constructive pericarditis, the restricted the pericarditis. Okay. The right-sided heart failure can do that. Pulmonary embolism, which is a cause of right heart failure, can cause it. Okay. Any tumors which are in the right atrium or the right ventricle, they can cause it. So any kind of obstruction in the right heart can cause it, you can say, which includes multiple causes. Okay. Any this constructive pericarditis or the restricted cardiomyopathy, they can cause it. But please remember, cardiac tamponade is not a cause of the small sign. Okay. Then comes the hereditary hemorrhagic telangiectasia, also known as the Osler-Weber-Rendow syndrome. In this scenario, you are having a formation of atrial in this scenario. Okay. And in multiple areas of your body, you can see the AV malformation or the AV fistulas. Okay. So symptoms can happen in multiple areas. Okay. First of all, you should know that this disease is an autosomal dominant disorder. Okay. You will have the telangiectasias, as the name suggests, in the multiple areas of the skin. Telangiectasias are the blanching lesion. Whenever you compress them, the blood will be lost there. You will have the paleness over the area. When you remove your finger, the reddishness will appear in the arteries in a spider web like pattern. Okay, and that's why it is the telangiectasias. Okay, in the nose, if the AV malformations occur in the nose, okay, it can lead to the epistaxis, which is the nose bleeding. Okay, it can have the skin discoloration. Okay, and in the GI tract, if they get the AV malformations, you will have the GI bleeding. You will have the bloody diarrhea sometimes. You will have the hematuria. Okay, if the AV malformation occur in the kidneys. Okay, and please remember that this thing is happening because of an impaired TGF beta signaling. If you guys remember from the general pathology section, we have discussed that the TGF beta is responsible for the angiogenesis. Along with the vascular endothelial growth factors, the TGF betas are also responsible for the angiogenesis. So when the defective signaling is occurring in case of TGF beta, it can lead to the hereditary hemorrhagic telangiectasias. Okay. Because of a formation of this AV fistulas, if you guys remember, that can lead to the high output cardiac failure. Why? Because the afterload is lost and the preload is increased. Heart is contracting too much, doing too many things, and as a result, it would be exhausted. Okay, and after the exhaustion, it can lead to the high output cardiac failure. Okay, the blood flow will be very much increased. Okay, so cells won't get the time to extract the oxygen. Other cause of it, right? You will get the pulmonary hypertension when the AV malformations occur. Remember, any kind of vascular changes in the lungs can cause the, please tell me disease name.
Hypoxic
Osteoarthropathy.
pulmonary
Osteoarthropathy. Okay, so we'll get the clubbing, right? And you will get a loud S2. You will get a dyspnea. Okay, you will get a very loud S2. Okay, then paradoxical embolism formations can also happen, right? The embolus can easily bypass the lungs because of these AV malformations and can enter the left side of the heart. So paradoxical embolus formations can also occur. Okay, cyanosis, clubbing, and the phenomena which is known as a platypnea can occur. Remember, I told you that in case of this myxomas, respiratory distress, and whenever you lay down, this distress will be relieved. Or symptoms with the laying down, and symptoms improve with the standing up. In case of platypnea, it is just opposite. Okay, so the pulmonary involvement, GI involvement, kidney involvement, nose involvement, skin involvement, all of these things are there in the Osler-Weber-Rendow syndrome. We can even have this brain involvement. You can have AV malformations in the brain, okay, which appears, I think, as a worm of a bag-like appearance on the angiography sometimes. Okay, and if it rupture, it can cause the brain hemorrhage, which can lead to the death of the patient. So in the brain, if it happens, it can cause the hemorrhagic stroke. Very important. Step one will ask you, they will give you a history of a patient who is kind of not, asymptomatic just for a regular checkup, and you did some CT scan, okay, and you get these kind of lesions Okay, it's just like a worm of a bag or some kind of flow white thing. We will discuss that later. And they will ask you, what could be the complication of this disease. It would be a hemorrhagic stroke. Very important. Okay, so any doubt on this Osler-Weber-Randolph syndrome? Anyone? Any doubt?
No.
Okay, so we are done with the cardiology, embryology, physiology, and the pathology. And now we're going to discuss the pharmacology after a short break. Okay, we will discuss the pharmacology and we will end this chapter today. Okay.
Okay.
For the hypertension, first you need to understand the BP. Okay, BP is equals to the cardiac output times the total peripheral resistance. Okay, so whenever you increase the cardiac output, the BP will increase. Whenever you increase the total peripheral resistance, the BP will increase. Okay, how you can change the cardiac output? By increasing or decreasing the heart contractility, heart rate, stroke volume. Okay, and the volume of blood inside your body or the fluid inside your body, right? How you can change the total peripheral resistance? By changing the arteriolar tone, okay, by vasodilation or by the vasoconstriction. Okay, so for every drug you study, they either increase or decrease the cardiac output, or they change the total peripheral resistance. Okay, so for the cardiac output, you can decrease the contractility, you can decrease the heart rate. Okay, this could be achieved by the beta blockers. Okay, you can decrease the cardiac output by decreasing the circulatory blood volume. Okay, and that could be achieved by the diuretic therapies or the ACE or the ARB drugs. Okay, the angiotensin converting enzyme inhibitors or the angiotensin receptor blockers. They reduces the body volume, and that's why they can reduce the cardiac output. Okay, drugs that can cause the vasodilations, they can they reduces the total peripheral resistance, and that's how they can reduce the blood pressure, like the calcium channel blockers, right? Like the alpha blockers, like the like these nitroglycerin, for example, nitroprusside. Okay, the alpha 2 activators. Okay, and the phenol-dopam, for example, the D1 receptor activator. Okay, the all drugs can cause the vasodilation and hence can decrease the BP. Can anyone tell me name of one or two drugs for alpha 2 stimulators? Alpha 2 stimulator drug name? Clonidine, Hydropa. Yeah. Yes.
Yes.
Please remember, don't forget the drug names. They are very important. Okay, so for the primary or the essential hypertension, you use the thiazides, you use the ACE, you use the ARBs, you use the calcium channel blockers. Okay, just like we have discussed, they all can reduce the cardiac output. They all can reduce the total peripheral resistance. Then for the hypertension with heart failure, beta blockers are very effective therapies. ACE and ARBs, because they all have a morbidity benefits as well as the hypertension benefits. You can use these drugs. Diuretics can be given, but beta blockers are contraindicated in the acute scenarios. Okay, and also in the cardiogenic shock, because it further reduces the contractility, can worsen the symptoms. Okay, you can also use the naptylysin inhibitor, which is a sacubitril. Okay, along with the angiotensin receptor blocker therapies. Okay, they have the mortality benefits as well as the hypertension benefits. Drugs that you can be used with the diabetes includes the angiotensin converting enzyme and the ARBs. These are the renoprotective drug in case of diabetes. They protect your renal vasculature and the kidney completely. The calcium channel blockers are very helpful. thiazide diuretics, beta blockers, but beta blockers must be given very carefully because they mask the hypoglycemia symptoms. Okay, but what are the two symptoms which these beta blockers can never be masked?
Diaphoresis, sweating,
Exactly, and the hunger.
hunger.
Then comes the hypertension in asthma. Okay, you cannot give those beta blockers which are kind of non-selective ones. Okay, you have to give the patient only cardio-selective beta blockers. ACE, ARBs could be, angiotensin converting enzymes cannot be given. Why? Because they inhibit the degradation of the bradykinin also, and the bradykinin can cause the worsening of the asthma by increasing the cough, right? So ACE inhibitors cannot be given. ARBs, calcium channel blockers, thiazides, and the cardioselective beta blockers only you will use in the hypertension with asthma. Okay. Then comes the hypertension in pregnancy. Drug must be used very carefully because they can be very teratogenic. But the safe drugs are include hydrazine, labetalol, methyl dopa, and nifedipine. Very important. And you can remember them by the mnemonic he likes mine, neonate. H for the hydrazine, L for the labetalol, M for the methyl dopa, and N for the nifedipine. Very important. Now, how these drug therapies actually work? We have discussed this previously in the autonomic chapter already, that you have G protein coupled receptors. Okay, whenever the beta receptors, okay, like the beta 2 which are in your blood vessels, okay, whenever they stimulated, what gonna happen? They will stimulate the adenyl cyclase. Okay, and the adenyl cyclase will convert the will convert the ATP or AMP into the cyclic AMP, and this cyclic AMP is an inhibitor of the myosin light chain kinase. Myosin light chain kinase. So ultimately, what's gonna happen? The myosin cannot be attached with the phosphate. Okay, if the energy is not available, then it won't be bind with the actin, and as a result, the relaxation will occur. Okay, and yeah, this is a function of all the drugs which act through the beta 2 receptors or the GS through, right? Then you have some other receptors like the GI. Okay, GI actually inhibit the cyclic AMP, so that they will they're actually activating the myosin light chain kinase and making the contraction, the vasoconstriction. Okay, drugs like the calcium channel blockers, they inhibit the calcium entry inside the cell, and as a result, calcium induced calcium release cannot happen. Calcium calmodulin complex cannot be formed. As a result, the enzyme can never be activated, and the contraction won't happen. Drugs which are GQ agonists, okay, and like your give me a second, the muscarinic activators, okay, which act through the IP3 DAG system. Okay, they increase the calcium, okay, from the endoplasmic reticulum. Okay, and then this calcium and the IP3, they will activate the enzyme. Which enzyme? Protein kinase C, if you guys remember, right? And ultimately, after releasing the calcium in the protein kinase C, you can have activation of myosin light chain kinase, which causes a contraction. So whenever you give the patient all these agents, epinephrine, norepinephrine, endothelin 1, angiotensin 2, vasopressin, they all act through the GQ receptors, can cause a vasoconstriction. Okay. Then comes the phosphodiesterase 3 inhibitor that we have discussed, the enamrenone and the milrinone. They inhibit the degradation of the phosphodiesterase 3. Oh, sorry, they actually inhibits the phosphodiesterase 3. Okay, so that the cyclic AMP can never be converted into the AMP, and as a result, the relaxation can happen. Drugs like and see you have the receptors of you have the muscarinic receptors in the endothelium, like we have discussed. In the endothelium, they causes the nitric oxide release, and which is by the arginine. Remember, arginine converted to which amino acid to release the nitric oxide?
Citrulline.
Okay, please remember this. Arginine will be converted to a citrulline, and the nitric oxide will be released. Now, this nitric oxide will be diffused into the smooth muscle cells in the arteries. Okay, and in the smooth muscle cells, they will release the cyclic GMP, and the cyclic GMP will activate the enzyme myosin light chain phosphatase, which remove the phosphate from the myosin so that the contraction could be inhibited and the relaxation can occur. Okay, this is the working action of the nitrates, the nitroglycerin. They work by directly secreting the nitric oxide in the smooth muscles. The relaxation can happen. Okay, drug like the acetylcholine, which work through the muscarinic receptors, they does the same thing. They release the nitric oxide in the endothelium. From the endothelium, it will reach to the this smooth muscle cells. Histamine, they work through same action. Okay, and cytokines, they work through same action. Bradykinin in other areas. Okay, other drugs also. Then the drug, which is a sildenafil, the phosphodiesterase 5 inhibitor, and this phosphodiesterase 5 converts the cyclic GMP into the GTP back. So if you inhibit the phosphodiesterase 5, cyclic GMP level could be increased. You will get the action. Okay. You have the ANP, BNP, and their analog, which is an aceretide. Okay, which releases the which work through the cyclic GMP. If you guys remember from the last lecture, okay, you will have the high GMP levels that can cause the phosphatase activity high, which will cause the relaxation. So these are the different drugs. That's how different drugs acts in the blood vessels and can cause the vasodilation. Okay. Let's discuss the calcium channel blockers. They block the calcium channels so that the calcium-induced calcium release can never happen. Calcium calmodulin complex can never happen, and as a result, the myosin light chain kinase is inhibited. Okay, myosin cannot be binded to the phosphate, and contraction will never happen, and as a result, the vessels will be dilated. You have two type of calcium channel blockers. One are the dihydropyridines, which are mainly act on the vascular smooth muscles, and second are the non-dihydropyridines, which are mainly act on the heart muscles, the myocardium. Okay. Dihydropyridine ones includes amlodipine, the clavadipine, nicardipine, nifedipine, nimonidipine. Okay. And non-dihydropyridines, they include the verapamil and the diltiazem, only two. Okay. And in order to dilate the arteries, you need to dilate the arterioles, very important. Because to dilate the arterioles, if you guys remember from the last lecture, you have a the coronary steal phenomena. Remember, if you have the atherosclerosis, the part which is already maximally dilated, it can never be further dilated, and the normal part, they will become dilate, and so that every blood, will go through there, not through the ischemic area, and you will get a further ischemia, the Steele syndrome. Remember?
Yes.
So these drugs take part in the coronary Steele syndrome. Okay, very important. Mechanism we have discussed. They block the calcium channels, and please remember they are the L type or the long type calcium channels. You have no drug which inhibit the T type calcium channels. Okay, only L type calcium channel inhibitors are available. Okay, very important. Then yeah, they do not affect the skeleton. Stephen will ask you, if you are giving a patient calcium channel blockers, then calcium influx of the calcium is also required for the skeletal muscles to cause the contraction, right? And if you give the patient calcium channel blockers, then why does the contraction of normal skeletal muscles is happening, but not the cardiac muscles? Well, this is because for the skeletal muscles, you have the endoplasmic reticulum, also known as the sarcoplasmic reticulum. Okay, and they contain all the calcium. Okay, there won't be any outward, there won't be any influx of the calcium from outside environment. Okay, every calcium which the cell need for the contraction is available inside the sarcoplasmic reticulum already. Okay, and that's why these drugs, they do not have any effect on the skeletal muscles, just the heart muscles and the smooth muscles. Okay, because they require the extracellular calcium influx to cause the contraction. Okay, then let's talk about the clinical uses. All of these drugs can be used for the hypertension. Okay, nimonidipine has a special use. It can it prevents the subarachnoid hemorrhage in case of subarachnoid hemorrhage. Just give me a second. In case of subarachnoid hemorrhage, okay, you have a complication which is a cerebral vasospasm. Okay, after subarachnoid hemorrhage, 3 or 4 days later, the patient can experience a cerebral vasospasm. To prevent this condition, you will give the patient nimonidipine. Very important. Okay. Then nicardipine and the clavadipine, Okay, you use these drugs in the hypertensive urgency or emergency. Very important. Whenever you encounter a patient having a BP more than 180 and 120 with some end organ damage or without end organ damage, you will immediately give those patients the clavadipine or the nicardipine. Okay. Then for the non-dihydropiridine calcium channel blockers, you can use these drugs for the treatment of hypertension to reduce the cardiac output because, right? You can use them for the angina because they reduce the contractility and the heart rate, so ultimately decreasing the oxygen requirement. Okay. You can use them as the antiarrhythmic agents. They belong to a class 4 antiarrhythmic agents. Okay, so use them for the supraventricular tachycardia like the atrial fibrillation and the atrial flutter. Very important. Adverse effects, very important. They all can cause a gingival hyperplasia. The growth of gingiva will occur. Okay. The dihydropyridine ones, they can cause a peripheral edema. Can anyone tell me how?
Because of vasodilation.
Okay. What's gonna happen after that?
Raised raised hydrostatic pressure in the vessels, leading to filtration of the fluid in the interstitial space.
In what
and
vessels?
edema in peripheral blood vessels. I think arterioles.
In arterioles.
Yeah.
The edema always occurs in the capillaries. Okay.
Sorry, capillaries. Yeah, they are
Don't forget
capillaries.
that. Okay, so
Okay.
they will cause a dilation of the arterioles, so the blood supply or the blood flow through the capillaries will be increased, and as a result, the hydrostatic pressure would be increased, so they can cause a peripheral edema. And because of the arteriolar dilation property, they will increase the blood flow to the periphery system. They can cause the flushing, redness. Okay, they can cause a dizziness. Why? Because they are reducing the blood pressure. They can cause the orthostatic hypotension. Okay. For the non-dihydropyridines, which are the cardioselective ones, they can cause a cardiac depression, the AV block. Okay. A very important thing, they can cause the hyperprolactinemia, especially true for the verapamil. They can cause the gynecomastia, they can cause the hyperprolactinemia, very important. Okay. And they can cause the constipation. Okay. They can cause the constipation because smooth muscles are also present in your GI system. Okay, they will inhibit the smooth muscles there and they can cause the constipation. So if you encounter a patient who is having a history of any arrhythmia, okay, now the arrhythmia is in under control, the patient is having a slight bradycardia, and the patient along with this thing is having a constipation also. So they will ask you, what is the cause of this constipation? So it is a class 4 antiarrhythmic drug or the non-dihydropyridine calcium channel blockers. Very important. Then the hydralazine, okay, which acts to the cyclic GMP, okay, that causes the smooth muscle relaxation and specifically for the arterioles more than the veins. So that causes mainly the afterload reduction. So if I draw, because this is very important, if I draw a pressure volume curve, okay, for a normal heart, like this is for a normal heart, okay, what changes in this pressure volume loop I can expect if I give the patient hydralazine. This is the end diastolic volume. Okay. This is the end systolic volume. This is the pressure. Okay. These are the pressure values. So what's going to happen to my end diastolic volume if I decrease the afterload? This line.
It will decrease.
Decreases.
My end diastolic volume will decrease. Is it because of loss of afterload or because of the venodilation?
Reduced afterload.
Afterload.
How does an afterload can reduce the end diastolic volume?
Because the end systolic volume will decrease because of the high cardiac output.
So what? I can still get a high preload because whatever the blood I pushed out of my system will be come back into the heart, right?
Yeah.
So it is because of the venodilation. See, you have a slight venodilation also. So they have a reduced preload. That's why a reduced preload. Okay. What happens after the afterload is reduced is the pressure to which my ventricles are going, it will be decreased. Okay. The pressure up to which my ventricles are going, it would be decreased. And because of loss of the afterload, you're having a loss of end systolic volume. It would be decreased. Okay. So a graph would be like that. But the contractility will be remaining same. Okay. If this is a contractility, it will remain same. You will get this kind of a graph. Okay. Step 1 will ask you this: what changes you can expect in the pressure volume loop if you give the patient hydrazine. So remember, contractility will remain same. Okay. Afterload, whenever the afterload decreases, the highest pressure to which the ventricle can go, this would be decreasing, not the preload, right? If it is a selective drug like the like for example the phenol-dopam, in this case you won't get to see the reduced end diastolic volume. Okay, because preload will be normal, right? So that's why, in case of venodilation, it will be a slight reduction, not a major reduction, but only a slight reduction. Okay. And ultimately, your stroke volume will be increasing. Okay. That's thing. Remember these facts. Okay. Now, because of the vasodilation, you have the arteriodilation, you have a loss of blood pressure. The sympathetic system will become activated, but the sympathetic system cannot do anything for the vessels. Okay. So sympathetic system just act on the heart. It will increase the heart rate. It will increase the contractility, and ultimately the cardiac output will be increased. Sympathetic system also go to the kidney. They will stimulate the beta receptors. They will cause the RAS activation that can lead to a sodium and the water retention. Very important. In the kidney, it can cause a sodium and water retention. And in case of heart, it can lead to the high cardiac output and high heart rate. Okay, tachycardia can happen, and that's why these drugs are generally administered with the beta blockers to prevent the reflex tachycardia. Okay. Adverse effects, because these drugs are metabolized by the acetylation. Remember the HIP3 drugs. Okay, so they can cause a drug-induced lupus. Okay, they can cause a tachycardia, and because of the tachycardia, the heart, the demand of the heart would be increased. Okay, so they are contraindicated in the angina, because in angina you don't want to increase the heart demand, right? Fluid retention can occur. Why? Because of the RAS system activation, right? Headache can happen because of the vasodilation in the brain, right? Angina symptoms can occur because of increased demand of the heart. Okay, these are the side effects. Then comes in a state of hypertensive emergency, when you have a BP of 180 and 120. Two drugs we have already discussed, the nicardipine and the clavadipine. Okay, one drug you guys know, which is labetalol, which is used for the hypertensive emergency state. Okay, other two drugs are the phenol-dopam and the nitroprusside that we study here now. Now, this nitroprusside actually causes a balanced vasodilation. Okay, it causes a vasodilation of the arteries as well as the veins. So both the preload as well as the afterload are decreased. Okay. Now, because the preload and afterload both are decreasing, what's going to happen to my sympathetic stimulation? It would be increased. And as a result, the cardiac output will be increased. Heart rate would be increased, just like your hydrazine. Okay. How does this work? It will causes a direct release of nitric oxide in the bloodstream. So this nitric oxide go both in the veins and as well as in the arteries. So causes a balanced vasodilation. Okay. But a side effect of this drug is the cyanide toxicity. It will release a cyanide that can cause the cyanide toxicity. Can anyone tell me what does cyanide do in my body?
Electron transport chain inhibitor.
What
Four.
complex? Complex 4, yes.
Four,
And how
Four,
can I treat
four
a,
complex.
yeah, and how can I treat a toxicity?
By giving vitamin C.
Vitamin C. Are you sure?
Cyanocobalamin.
Exactly. Vitamin B12, cyanocobalamin,
Yes.
or other
Yeah,
drug.
cyanocobalamin. Yeah.
Other drug? Yeah.
Amyl nitrite.
What drug?
Amyl nitrite.
Sorry, I didn't understand. You can please write it down in the chat box.
Sodium thiosulfate.
Yeah, sodium thiosulfate. Yes. And any other thing?
Nitrites.
Amyl nitrite.
Yeah, exactly. Yeah, nitrites. Why nitrites?
Because it's going to bind the cyanide and get rid of it.
They convert it back to Fe3.
Yes. The methemoglobin, if you guys remember, okay? Methemoglobin, it will readily bind to the cyanide. Then you will treat the methemoglobin by giving the patient vitamin C, okay? That's how it works. Then comes the phenol-dopam. You guys already studied it in the autonomic chapter. Okay, it is selective D1 receptor agonist, and you can even tell me how the D1 receptors work. What kind of G protein coupled receptors they are?
Which ones?
D1 receptors, which
GS.
GS type. Yes, they will cause a vasodilation, and especially the renal vasodilation to increase the renal blood flow. Okay, and whenever the renal blood flow is increased, what's gonna happen to my GFR? It will be increased. The delivery of the sodium and the water will be increased. RAS will be inhibited, and what you get is the natriuresis. Okay, so they are especially beneficial whenever the patient is having a renal disease, specifically, right? Very important. But all of these agents can get a reflex tachycardia. Okay, and the reflex increase in cardiac output. Okay. Then comes the nitrates. Nitrates, they also releases the nitric oxide, but especially in the venous smooth muscles. Okay, so they are most commonly causes the venodilation and a slightly arteriodilation also. Okay, mainly the veins and slightly the arteries. So mainly they decrease the preload and slightly they also decrease the afterload, right? The drugs includes nitroglycerin, okay, isosorbide dinitrate and isosorbide by mononitrate. Okay, this is the oral form and this is the IV form. Sublingual and sublingual and the oral form. Okay, and that's why you need to give the patient ISDN in a very high amount than the nitroglycerins, because you are giving them with the oral route, so they have to go through the high first pass metabolism, right? So always in a high amount if you're giving them in the oral dose. Okay, for the sublingual form, because the blood vessels, the veins uh, from the tongue that directly put blood into the vena cava, and that's why they are bypassing the liver. So just a small amount is enough. Use of the nitrates for the angina, for the acute coronary syndrome, and for the pulmonary edema, very important. You have only 2 or 3 drugs for the pulmonary hypertension and pulmonary edema. One of them is the nitrites. Okay. Adverse effects, because of the RD dilation and because of the reducing the preload, they can cause a reflex tachycardia, okay, which will be treated with the beta blockers. They all can cause a hypotension because of loss of cardiac output as well as decrease in the total peripheral resistance. Because of increase in the and because of the vasodilation, they can cause a flushing. They can cause the headache. Okay, this is a Monday morning sickness because some in case of any industrial exposure. Okay, whenever the patient come into the industry after a Sunday, after a break, they will cause a sudden attack of the headache because of vasodilation. Okay, but what happens after some time, the tolerance will develop. Okay, and what does this phenomena known as?
Tachyphylaxis.
Tachyphylaxis. It will happen, and as a result, the patient will have a less vasodilation. Their headache will be improved after 2 or 3 days. Okay, but again, after Saturday, when they take a break at Sunday, and then again go back to the work on Monday, they will get again the headache. Right? This is a Monday morning disease or Monday sickness. Okay. Then other thing, tachycardia, dizziness, headache. We have discussed that. That contraindicated in the right ventricular infarction. Can anyone tell me why?
Because blood pressure is already low.
So they must be contraindicated in left one also. But why only the right?
In right ventricular infarction, because of low cardiac output, there will be less blood flow to the forward system. So if we further lower the blood pressure, like with
Decreased
nitrates.
preload.
Well, then that must be true for both, right? For the right as well as left.
Nitro further decreases the preload.
Yeah, exactly. It is a preload.
Yeah.
Okay, that's why it is contraindicated in the right ventricular infarction. And it is also contraindicated in the hypertrophic cardiomyopathy. Why?
Again, same.
Because
reason,
of
preload
because
decreasing.
of the reduce in the preload, they're
the-
reducing the blood volume, right? And that's
Yeah,
why.
it increased the obstruction.
Yeah, exactly. And concurrently, if you are using any PD5 inhibitor like the sildenafil, you cannot use these drugs because it will cause further vasodilation and further hypotension. So contraindicated with the other PD5 inhibitors. Okay, very important. And remember the pressure volume loop for these nitrates, you will have a loss of preload. So the end diastolic volume will be decreased. You have a loss of afterload. So the pressure is also decreased, but the contractility will remain same. Okay. So this thing you will get. And yeah. And what kind of a pressure volume loop you will get in case of nitroprusside? Let's discuss this also. Just give me a second. Okay. This is my normal loop. What changes will I get in this loop after giving the patient nitroprusside? What's going to happen to my end diastolic volume?
It would decrease.
Decrease.
Increase.
Increase.
Decrease.
Why increase? Those who are saying increase, why increase? See, you're having a venodilation.
Yeah.
And whenever the veins dilated, they will have a pooling of the blood, right? So the preload will decrease, not increase. Okay, so one thing is the decrease in the preload. Okay, higher. And what's going to happen to my afterload?
Decrease.
It will also be decreased.
Decrease.
Yeah, exactly. What's going to happen to my contractility?
Same.
Same.
And what's going to happen to my end systolic volume?
Decrease.
Yeah, say it decrease, because if you are having a low preload with the same this contractility, okay, 70% will be 70% of the blood will be ejected, and you will left with a less end systolic volume. So it would be a graph like this. And please remember, this contractility must remain same. So this graph would be something like that only. Okay, this is what you get. Okay, step 1 will ask you the changes in the loop whenever you give any of these 3-4 drugs. So you must remember. Okay, I mean, not remember, just analyze for yourself. Okay, nothing to remember on these graphs. Okay, if you understand the concepts, everything is good. Okay, so any doubt on this page?
No.
No, thank you.
Then comes the anti-anginal therapy. Okay, most of the goal is to match the this supply and the oxygen demand. Okay, for the angina, you just need to match the supply of the oxygen as well as the demand of the oxygen. Okay, this is your goal ultimate. Okay, and this could be done by multiple drugs. Okay, and all of the drugs, they either reduce the BP, heart rate, contractility, or the preload. Okay, ultimately reducing the oxygen demand of the myocardium. Okay, the true drugs include the nitrates and the beta blockers, which are mainly used for the anti-anginal therapy. Okay, first let's talk about what changes can happen with the nitrates. We have discussed that already. In case of end diastolic volume, this would be decreased. BP, of course, decreased because of loss of preload and and a slight loss of afterload also. Contractility, because of a sympathetic response, it will be increased. Heart rate would be increased. Ejection time would be decreased. Why? Why ejection time is decreasing? No one? See, you're having a high heart rate, and having a high heart rate means decrease in the systole time as well as decrease in the diastole time. Is that okay? Yes?
Say it again.
You have a high heart rate. In order to get a high heart rate, you have to decrease your systole time as well as your diastole time. Yes?
Okay.
And if you're and when does the ejection happen? In systole or in diastole?
Systole.
Systole.
And you're having a reduced systolic time. That means a reduced ejection time. Okay. The
Yeah.
demand of the oxygen is of course reduced because of loss of preload and loss of afterload, right? And what's gonna happen if I give the patient only the beta blockers? Well, for the end diastolic volume, they have or no effect or a slight increase because they causes the beta blockers in both the arteries, okay, and as well as kind of uh, you know uh, no effect on the veins, right? So preload it won't change, and diastolic volume will remain same, okay. Second thing is the blood pressure. Of course, it will be decreased because of beta blocking effect on the heart, right? For the contractility of the heart, it would be reduced heart rate, reduced ejection time because the heart rate is reducing. Both the diastole as well as systole is increasing. So you will get a high ejection time. Oxygen demand is ultimately reducing, but one thing is limiting the reduce in the oxygen demand. And this is the diastole filling time. Because the diastole filling time is increased, ultimately the volume of the blood is also kind of slightly increased, as you can see. Because the diastole filling time is increased, the end diastolic volume either it would be normal, okay, because of the preload decrease, but the filling time is because increasing, you can get an increase in the volume also. So this is a kind of limitation for the beta blockers to decrease oxygen demand. So you generally combine the nitrates and the beta blockers to get a combined effect. Okay, in case of end diastolic volume, you have either no effect. In case of BP, it would be of course decrease because both are decreasing it. In case of contractility, no effect. Heart rate, no effect. Ejection time, no effect. Oxygen demand is very severely reduced. So for the angina, you give the patient beta blockers and the nitrates. Okay, very important. Verapamil, they work very similar to the beta blockers. They inhibit the calcium channels in the myocardium so that contractility and heart rate would be reduced. Pindolol and acebutolol, they have a partial beta agonist effect. Okay, so you always want to use them with caution in case of angina, because if if a complete agonist agent is present, then they can cause the antagonist effect. If no agonist agent is present, they can cause the agonist effect, if you remember. Okay, so use them very carefully. And along with the angina, if the patient is having a history of COPD or any asthma, okay, then you must not use the non-selective type beta blockers. You must use a cardioselective ones only. This is a very important thing. And sometimes when you abruptly stop the beta blockers, you can experience a beta blocker withdrawal syndrome. Okay, it could be a patient who just ran out of medicines and forget to fill it. Okay, so they can get a beta blocker withdrawal syndrome. What happens with the prolonged use of the beta blockers? You're actually inhibiting the receptors, right? And with the receptors inhibition, your body try to compensate it by increasing the receptor density, right? And because now receptor density is increased, okay, and these catecholamines are already very much high in the amount, okay, because of the blocking effect. So what's going to happen if you suddenly stop the beta blockers? The blocking effect is gone. Now this high catecholamine and high beta receptor density, they will cause a very combined symptoms. Okay, very important. That's why you will get a beta blocker with also you get a very high heart rate, a high contractility, a high blood pressure. Okay, blurring of visions can occur, headache can happen, and all of these things. Okay, suspect in the patient who abruptly stop taking the medications. Then comes the ranolazine, which is a drug which inhibits the late phase of invert sodium. If if you guys remember, let me notate it. You're having this cell, okay? And in this cell, you're having two receptors. Oh, sorry, two channels. Okay. One is the sodium calcium channel, okay, which is this one, and one is the sodium potassium ATPase channel, right? For the sodium potassium ATPase, they will throw out the sodium, okay, and they will influx in the potassium, right? This is their function. For the sodium calcium channels, they will causes the influx of the sodium and the outflux of the calcium, right? This is the outflux of the calcium and this is the influx of sodium, right? If you block the late forward phase of inward sodium current, if you inhibit the influx of the sodium, then what's gonna happen? The intracellular concentration of the sodium will be decreased. Okay, and if the concentration of the sodium is decreased, then what's gonna happen to the sodium calcium pump? The activity of this pump will increase or decrease?
Decrease.
Decrease. You're saying decreasing, right? Yes. See, they are throwing the sodium from outside to inside. Okay. If I decrease the sodium here, then they have no sodium for the influx, right? But they still, but in this scenario, they have the sodium on the outside. If I decrease the sodium concentration here, then what's going to happen? The concentration will be low here, concentration will be high here. As a result, a concentration gradient is established. So it will further activate this pump. Okay. And when the pump get activated, what does it causes? It will cause the more influx of the sodium and more outflux of the calcium. And now you can see the concentration of calcium is decreased. And when the concentration of calcium is decreased, what's gonna happen? The contractility will be reduced. Okay. Yes. And as a result, the oxygen consumption will also be reduced, but they have no effect on the heart rate or the blood pressure. Very important. They have no effect on the heart rate or the blood pressure, just reducing the contractility. Okay, and the oxygen demand mainly, not the contractility very much. They're just reducing the oxygen demand, not even the contractility this much. So yeah, no effect on the BP, just a reducing the oxygen demand. So that's why you can use the ranolazine for the angina therapy. Okay, then comes the sacubitril drug, which is a naphthalase inhibitor, and like we have discussed, this naphthalase actually inhibits or degrades the ANP and BNP. So if you use this drug, the the concentration of the ANP and BNP will be increased. Okay, and you will get the symptoms, of course. So you use this drug only for the heart failure. Now, because this naphthalase is also involved in the degradation of the angiotensin 2, very important. This naphthalase is also involved in the degradation of the angiotensin 2. So if you give the drug, what's going to happen? The concentration of ANP and BNP will increase. But at the same time, the concentration of the angiotensin 2 will also be increased, right? And that's why the angiotensin 2 receptor inhibitors, okay, which are the ARBs, they are also given along with these drugs. Okay, very important. And please note that ACE inhibitors are contraindicated with this naphthalase because it is also involved in the bradykinin degradation. Naphthalase is also involved in the bradykinin degradation. So if you give these drugs, ACE inhibitors along with the naphthalase, it can further rise the level of bradykinin, which can cause the angioedema. So you do not use the ACE inhibitors, but you use the ARBs, the angiotensin receptor blockers, along with the naphthalase. Combination therapy is given to treat the heart failure and to treat the other conditions. Okay, and mainly for the heart failure with reduced ejection fraction, like we have discussed previously. I've told you in the heart failure part that you use this drug along with the ARBs also. Okay, although I didn't mention that here, but they have mentioned it here. Okay, they can cause a hypotension, they can cause the hyperkalemia because of this ARBs. Generally, you give them with the ARBs, that can cause a hyperkalemia, of course. It can cause a slight cough because of bradykinin inhibitors. Okay, because the neprilysin is actually causing the inhibition of the bradykinin, but now the bradykinin is too much. That can cause the cough. Dizziness can occur. Okay, that would be everything. So any doubt on this page?
Can you repeat? I'm not understanding the use of sacubitril.
See. See, you have the ANP, right? You have the BNP. Remember, I told you this ANP and the BNP, they will be degraded by the what thing? What enzyme? Neprilysin, right? Right? Not just these drugs, but the angiotensin 2 and the bradykinin also, they will be degraded by the neprilysin. Is that okay up to here? These four things, ANP, BNP, angiotensin 2 and the bradykinin.
Yeah.
Okay. They all will be degraded by the neprilysin. Okay. Now, if you give the patient sacubitril, which is this neprilysin inhibitor, okay, what gonna
Okay, I
happen?
get it. It's not going to break them down. It's going to vasodilate.
So ultimately, the ANP, BNP level will rise, right? But at the same time, the angiotensin 2 and bradykinin levels are also rising. So you have to give additional drug which inhibits the angiotensin 2 function, which is the angiotensin 2 receptor blockers, the ARBs. But you cannot give the patient angiotensin converting enzyme inhibitors because, after giving the patient neprilysin inhibitor, sacubitril, they're also raising the bradykinin levels. So ACE are the contraindicated. ARBs should be used with the neprilysin, with the sacubitril. So they provide in the heart failure both the mortality benefits and of course it will reduce the BP of the patient, right? So they're generally used with the valsartan or the ARBs to treat the heart failure with reduced ejection fraction.
Okay.
Is that okay?
Yes, I understand.
Any more doubt on this page? Then now discuss the lipid lowering agent. First, we need to discuss the pathways that we have already discussed in the biochemistry lectures. I have told you that in the liver, you have the acetyl coenzyme A, which is formed by the free fatty acid oxidations. Okay. It will undergo by the enzyme HMG-CoA synthetase, which will form the HMG-CoA. Then HMG-CoA reductase. Just give me a second, guys. So yeah. So in the liver, you have this HMG-CoA and formed, okay, and by the action of enzyme HMG-CoA reductase, you are forming the mevalonate, and then ultimately it will form the. I'm not sure about the first name you're talking. I'm just know about the sacubitril, and Teresto, I don't know about it. Okay, so ultimately it will form the cholesterol. And can anyone tell me what enzyme is responsible for the ketone synthesis?
Oxybutry.
Ketone synthesis. Anyone?
Part one.
What? From the biochem, please try to remember. I have told you specifically to know these two drugs. One is for the cholesterol and one is for the ketones. HMG-CoA lyase. Okay, don't forget that. Lyase for the ketones and this reductase for the cholesterol. Okay, once the cholesterol is formed, it will be packed in the VLDLs. Okay, secreted into the blood vessels. From there, they meet with the HDLs. They transfer some of their receptors to them. Ultimately, they will go to the adipose tissue, transfer their free fatty acids, and it is by the enzyme, this lipoprotein lipase, which is upregulated by which of the apolipoprotein?
C2.
ApoC2, yes, ApoC2. Similarly, from the dietary fats, it will be packed in the chylomicrons. They are in the blood. They will meet the HDL. They take some of the receptors like C2, B4, and other receptors E. Okay, C2 and E. Free fatty acids are delivered to the adipose tissue. Okay, and finally the LDLs will be converted to the VLDLs will be converted to the LDLs. Okay, and from the VLDLs and from the LDLs they will be converted into the IDL by the liver. Okay, and IDL will be go to the these are the LDL, as you can see. It will be again rechanged into the sorry, there missed something. So VLDL will be converted into the IDL first, right? The IDL go to the liver, repack again, and they will become the LDLs, right? LDL has the receptors which are known as the LDL receptors. Okay, LDL receptors are present on the liver and other adipose tissues. From the LDL receptors, they will be uptaken by the liver and other tissues in the body, and that's how cycle works. Okay, so all of these drugs that we're going to study now, they will work on any of these pathway. Okay, first drugs are those drugs which inhibits the the reabsorption, which inhibits the absorption of the fats from the GI tract. Okay, so the first one is the azatamib, which inhibits the cholesterol absorption. See, only the cholesterol absorption, no other thing. Okay, and as a result, the cholesterol won't be absorbed. Okay, so cholesterol cannot be present in the chylomicrons, and this is a one way to lower the cholesterol levels. Okay, second drugs are the bile acid reabsorption inhibitors. Okay, what's gonna happen? They will inhibit the absorption of the bile acid from the and as a result, vitamins, fat soluble ones, acids reabsorption, and as a result, the fat will be lost in your stools. So because of that, you will get the diarrhea, very important. You will get the deficiency of fat soluble vitamins. Okay, very important. Then those drugs which upregulates the lipoprotein lipase, and these drugs includes the fibrate therapies like the gemfibrosal, fenofibrate, benzafibrate. All of them have a fibrate in their name or the fiber in their name, a FIBR. Okay, they upregulate the lipoprotein lipase so that more free fatty acids could be released from the VLDLs and the chylomicrons, so that it could be stored in the adipose tissue. Okay. Then similarly, with the LPL regulation, these drugs also inhibit the hormone-sensitive lipase. Two functions. One is the LPL regulation, and second is the inhibition of hormone-sensitive lipase, so that at the time of fasting, when the hormone-sensitive lipase become activated, it will release the free fatty acids from the adipose tissues by the lipolysis into the bloodstream. So this could be inhibited by the fibrates also. Other drugs like the niacin, just the same thing. They inhibit the hormone sensitive lipase so that free fatty acids cannot be released. Okay. Then come those drugs which inhibit the cholesterol formation in the liver, and these are the statins. Okay, they inhibit the HMG-CoA reductase, so that these all of these drugs, they include the statin in their name at the end. Okay, they inhibit the cholesterol formation. Okay, so that what's going to happen now, the cholesterol is not synthesizing in the liver. So every cholesterol which is present in the blood, like the LDL, because LDL has the most concentration of the cholesterol, it would be uptaken by the liver. The receptor densities for the LDL receptor is very important. Sometimes, and now most of the times now, step one, they do not give you this enzyme name. They won't ask you which enzyme these statins inhibit. They just ask you what is the consequence of this statin therapy. This would be the upregulation of LDL receptors, very important. Okay, they will upregulate the LDL receptors so that by inhibiting the cholesterol synthesis, so that every cholesterol which is in the blood could be uptaken by the liver for the VLDL synthesis. Okay, then the drugs which inhibits the LDL receptor degradation, because PCSK9, if you guys remember from the biochemistry, these are some enzymes which inhibits or degrade the LDL receptors. So these drugs like alirocumab and the evolucumab, they inhibit the PCSK9 so that the receptor density would be increased. So these are the all drugs which we're gonna study now. First ones are the HMG co-reductase inhibitors like the statins. They decrease the LDL in the blood by upregulating the LDL receptors and as well as by inhibiting the synthesis of cholesterol by inhibiting the HMG co-reductase enzyme. They also increase HDLs, okay, and they decrease the triglycerides level. Okay, their function we have discussed already. Okay, and they all provide the mortality benefits in the coronary artery disease patient. Very important, like I told you, whenever you have a patient with myocardial infarction, you need to give them this statin therapy. Doesn't matter whatever the level of the cholesterol in their body is. Okay, the statin therapy is must. Adverse effects, it include the hepatotoxicity and the myopathy. They causes the muscle pain and the and the degradation of the muscles or the damage of the muscles to release the myoglobin. So they can cause the hematuria also, but not the real hematuria, of course. It will be the myoglobinuria, sorry. Okay, they can cause the myoglobinuria, red urine. They will cause the very pain in the muscle, high lactic acid level because of a muscle damage. Okay, and if you use these drugs with any P450 inhibitor, very important, if you use these drugs with any P450 inhibitor, they can increase the toxicity of these drugs and can cause the more myopathy. Okay, very important. And especially if you use these drugs with the fibrates, they can cause the myopathy again. Then comes the bile acid resins, like the cholestyramine, cholesterol. They inhibit the reabsorption of the bile. Okay, you must use the word reabsorption for the biles because bile is synthesized in the body, go into the GI system. From GI system, they will be reabsorbed, right? While other, other nutrients like fats, vitamins, they are absorbing, they are not reabsorbing, right? And the kidneys, everything is reabsorbing. So you use the words very carefully. Okay, so for the LDL, again, they will reduce the LDL, they will increase the HDL slightly, and they will also, very important, only the bile acid resins, they increase the triglycerides slightly. Okay, now because the the dietary cholesterol is lost, now your liver try to compensate it, okay, by increasing the activity of HMG co-reductase, and as a result, the synthesis of the cholesterol in the liver is increased. Overall, the cholesterol level will be decreasing in the blood, but in the liver, the synthesis of the cholesterol will be increasing. So these drugs are sometimes given with the statins to prevent this condition. Okay, they decrease the absorption of free fatty acids and the and the cholesterol and the fat soluble vitamins also. So they can cause the vitamin deficiency. They can cause a GI upset, diarrhea, very fatty diarrhea will be there, right? Ezetimibe, they inhibit the cholesterol reabsorption. The cholesterol absorption. So they will reduce the LDL level, slightly increase the HDL, and slightly decrease the triglycerides. You will use these drugs only when the statins cannot be given. Okay, like a patient who is having any hepatotoxicity or the patient who is having a muscle pain, you will use, instead of the statins, you will use the ezetimibe. Okay. Then the fibrates, gemfibrozil, fenofibrate, benzofibrate. Okay, they will slightly reduce the cholesterol, but they have a major action on the triglycerides. So in the hypertriglyceridemia or a hyperchylomicronemia, you will use the fibrates. Whenever the patient is having a diabetes or a risk of acute pancreatitis from the from this high triglycerides level, you will use the drug fenofibrates. Okay, they will upregulate the LPL, which is a lipoprotein lipase, so that the triglyceride clearance could be increased. They will also activate the PPAR alpha. Please remember this enzyme name. Okay, fibrates, they work through the PPAR alpha. And there's one more enzyme, which is a PPAR gamma. Can anyone remember what drugs work through the activation of PPAR gamma?
The diabetic drugs.
And what anti-diabetic drugs?
Thiazolidine
The glitz. I think.
Yes. Yeah?
thiazolidine diones.
Yeah, thiazolidinediones. Yes, exactly. Okay, so please remember alpha for the fibrates. And because alpha came first, then the gamma, okay, and you have the CVS first before the this endocrine. So PPAR alpha first, then the gamma and fibrates. Yes, and they also decreases the VLDL synthesis. Okay, very important. And they can cause the gallstones by inhibiting the enzyme 7-alpha hydroxylase, which is important for the synthesis of bile acids. Okay, and now because the bile acids are lost, they are not synthesizing, the cholesterol will be super saturated in the bile, and as a result it can form the gallstones. Very important. They can cause the myopathy with the if you use them with the P50 or other these statins. Niacin we have discussed inhibit the VLDL synthesis and increases the release decreases the release of free fatty acids from the adipose tissue. They will decrease the cholesterol, increase the HDL, and slightly reduce the triglycerides. PCSK9 inhibitors we have discussed. Fish oil capsules, they slightly increase the cholesterol level, okay, but decreases the triglycerides and increases the HDL level also. And one more thing for the niacin, they increases the release of prostaglandins, so they can cause the pruritus and flushings. Okay, so you will use the NSAIDs or the aspirin along with the niacin as initial therapy. Okay, and yeah, that would be all about the lipid lowering agents. Any doubt? Any doubt? Anyone? Please ask.
No.
Then come the cardiac glycosides, which are the digoxin. We have discussed that it many times. Okay, it inhibits the sodium potassium ATPase pump by binding at the potassium site. Okay, extracellularly they bind at the potassium site so that the potassium cannot be influxed inside the cell, and as a result the pump is inhibited. Okay, sodium cannot go outside the cell, so the concentration of sodium will be increased inside the cell, and as a result sodium cannot come inside the cell from outside. Okay, this sodium calcium exchanger is inhibited. Calcium concentration secondarily will be increased. That will cause the calcium induced calcium release inside the cell, inside the myocardium, that can cause the contraction. So that's why these drugs are used in the heart failure with reduced ejection fraction. Second thing, these drugs also stimulate the vagus nerve, and because vagus nerve is a parasympathetic nerve, they all can reduce the heart rate, so they can also be used as the antiarrhythmic agents. So heart failure and the antiarrhythmic agents. Then comes the adverse effects, which are very important. They can cause the nausea, vomiting, diarrhea, just like normally. Okay. And the important thing is they can cause a blurry yellow vision. Whenever you encounter a patient, an old age patient who is having some yellowish vision, that means they are on the digoxin therapy. Okay. They can also cause the AV block because they are reducing the heart rate. They can cause the they're causing the AV block. Okay. They also can cause the hyperkalemia because they're inhibiting these pumps. So potassium cannot come inside the cells. Hyperkalemia will occur. Okay. And these drugs are actually excreted by the kidney. So toxicity will only be seen in the renal failure patients. Okay. Very important. And whenever the patient is on the hyperkalemia, whenever the patient is having a hyperkalemia, because it is a competitive binding at the potassium sites. Okay, so they will displace the potassium. So if the patient is already having a hyperkalemia, then patient can have a toxicity of the digoxin. Okay, very important. And verapamil, amiodarone, and quinidine, they will displace the digoxin from the protein bindings, from the tissue binding sites, and that's why the declarence of the of this drug is decreased. That can further leads to the toxicity. So toxicity you will always consider in the decreased excretion by the kidney, any renal failure case. Very important. Or a patient on the diuretic therapy sometimes. Okay, they can cause the digoxin toxicity. Antidote would be your anti-digoxin fragment antibodies. Okay, and you need to slowly normalize the potassium levels also. Okay, if these therapies are not available, you can give the patient magnesium. If it is not available, you can even give the patient lidocaine, which are the class 1B antiarrhythmics. You can use these agents for the digoxin toxicity also. Okay, so nausea, vomiting, diarrhea, and the coloring, decoloration will be very important. Okay, any doubt on the digoxin? Doubt? Okay, so then comes the antiarrhythmic agents. Okay, you will use these agents for the AFib, A-flutter, ventricular tachycardias. Okay, and we have divided them into the three classes. 4 classes: class 1, class 2, class 3, and class 4. Okay. For the class 1, you have 3 classes again: the class 1A, class 1B, and the class 1C. Class 1A drugs, class 1 drugs, they all inhibit the sodium channels. Okay, but along with sodium channels, they also can inhibit or activate the potassium channels also, right? For the class 1A agents, they inhibit the sodium channels as well as the potassium channels. For class 1B agents, they inhibit the sodium channels but activate the potassium channels. And class 1C agents, they only inhibit the sodium channels, no action on the potassium ones. And now, because class 1 agents actually inhibiting the potassium channels, they're prolonging the time for the potassium efflux. That means they can cause the QT prolongation because this phase 3 is prolonged. And you guys know that phase 3 belongs to the QT time, the T wave, okay, which is a repolarization wave, right? So T wave is prolonged, ultimately QT wave is prolonged, and you will get a QT prolongation that can cause the torsades. Okay, these drugs include the quinidine, procainamide, disopyramide, and because they have the activity on the SA node or on the myocardiocytes, tell me. They have activity on the nodes, SAAV nodes, or on the myocytes.
Myocytes.
Myocyte.
Exactly. They have activity on the myocytes, not on the SA nodes, right? Because in the SAAV node, sodium channels are not functioning, right? And because they're also acting on the, on this phase 0, they will decrease the slope of the phase 0. They will, they will prolong the phase 0 of the action potential. And as a result, the QRS widening will be seen. If you guys remember, the phase 0 belongs to the QRS. So you will get the QRS widening. You will get the QT prolongation. Okay. And ultimately, as you can see, this is the duration of the action potential. This is increased. Okay. The duration of the action potential is increased. Very important. And the effective refractory period, which means in that time, no new impulses could be generated. It will also be increased. Okay. Very important. Clinical use, they will use for the ventricular arrhythmias mainly. Okay. Although they can also be used for the atrial arrhythmias also. Okay. Effects, synchronism, SLE, if you guys remember, the HIP drugs, the procainamide, which is metabolized by the acetylation, it can cause the SLE. Okay, and they can cause the heart failure. They can cause a torsade de Pontes due to the QT prolongation. Okay. Then comes the class B agents, which activates the potassium channels, and as a result, and they inhibit the sodium channels. So basically, they are decreasing the slope of phase 0, but they're also reducing the duration of the phase 3. Okay, so they are causing the QT lessening. Okay, decrease the QT time. Plus, they will cause the QRS widening slightly. But ultimately, as you can see, the action potential duration is decreased. Okay, the action potential duration is decreased in these agents. Okay, you mainly use the class 1B agents only in the ischemic arrhythmias, which means the arrhythmia after the myocardial infarction. Very important. You use them for the ischemic arrhythmias, which means the arrhythmia after the myocardial infarction. So whenever you encounter a patient having a tachycardia, ventricular fibrillation after the myocardial ischemia, okay, or the infarction, you will use these drugs only. So for the MI case, always use the class 1B agents like the lidocaine and the maxidilline. Okay, because they have a specific, very preference for the ischemic tissues. Why for the ischemic tissues? Because for the ischemic tissues, they have the sodium channels in the open or in the inactivated state. Okay, their sodium channels can never return back into the normal state or the closed state or the resting state. Okay, and these drugs, they basically bind to the sodium channels only in the inactive state or the activated state, which is which is available in the ischemic tissue. That's why they have a preference for the ischemic tissue only. Okay, so whenever you hear a patient, read about a patient who is having a history of myocardial infarction and now having arrhythmia, always use the class 1B agents. Then comes the class 1C agents, the flecainide and the perpafferone. They have no effect on the potassium. They just causes the reduce in the slope of the phase 0, prolonging the phase 0, causing the widening of the QRS. Okay, you have to be extremely cautious while giving those drugs. Okay, you have to just give those drugs in a very normal myocardium. Okay, you cannot give this drug in the any ischemic or any structurally abnormal myocardium, otherwise they can cause further tachycardias or other arrhythmias. Okay, so make sure that the heart is structurally normal before giving these drugs. Okay, they have no effect on the AP duration, as you can see. Okay, and yeah, that would be all. And these drugs, they specifically works at a very higher heart rate. Okay, they have no effect on the lower heart rate when the patient is actually resting. They have no effect on the heart rate. But as soon as the patient start walking or start doing exercises, or the patient is having any arrhythmic episode, then only these drugs will become functional. Okay, these drugs are functional only at the very high heart rate, and this is known as the use dependence. This phenomena is known as the use dependence. If you look at the graph, this is a dissociation curve for the class 1A, 1B, and the 1C agents. As you can see, the dissociation of the class 1C drugs is very slow. Okay, so they have a very strong binding with the receptors. Okay, and when the receptors become when the receptors starting getting into the inactivated state or the activated state at a very higher heart rate, then only you can see the effect of these drugs. Okay, a cumulative effect you can see. Okay, this is a use dependence. So it would be a patient and you're doing experiment on him, like say you're giving him a drug. Two drugs are given to two different patients. You have measured the baseline ECG, baseline heart rate, and everything. Then you ask the patient to exercise after giving the drug, and you see that as the patient is exercising, the heart rate of the patient is decreasing. Okay, the ECG and the diastole systole will be all decreasing. Okay, you will see the QRS widening in the patient. Okay, and no effect on the QT time. That's how you know that the patient is having a class 1C agent. Okay, and as you can see, the class 1B agent, they have a faster dissociation rate. That means they have a little use dependence. Very important. They're not functioning at a very higher heart rate. Okay, any doubt on the class 1A, class 1B, or class 1C drugs?
Can you repeat the use dependence?
See, for the use dependence, the effect of the drug is increased at a very high heart rate. Okay, whenever the patient is exercising, walking, or doing any cardiac activity, or the patient is having a rhythmic episode, then only these drugs will become functional. Okay, they are not functional at a normal heart rates. They're functional only at the higher heart rate. So all the EKG changes, all the heart rate changes that you will see in these drugs are only when the patient is exercising or they have a very high heart rate, because they have a slowest dissociation from the receptors. Okay, so they have a cumulative effect. They will bind effectively when the cells are in the activated, when the sodium channels are in the activated or inactivated phase. Okay, which happens at a very high heart rates. Okay.
Okay, got it now. Thank you.
Then comes the class 2 antiarrhythmic agents, the beta blockers. We have discussed them already. They will reduce the CAMP, cyclic AMP, they will reduce the calcium currents, and as a result, the contractility is lost. Okay, they will also prolong this phase 4 of the depolarization. Okay, and how does it do that? Anyone remember what kind of channels are activated in phase 4?
Sodium calcium channel.
Sodium, calcium, and there's the potassium channels, right? So these channels are inhibited by these beta blockers, the potassium channels specifically, right? And that's how they will reduce the slope of the phase 4. As you can see now, the higher time, longer time is required to reach back to the same potential, threshold potential, to cause the depolarization and the action potential. So the heart rate is now decreased. Along with the phase 4, they also have an action on the phase 3. They will prolong the phase 3 also by inhibiting the potassium channels. Okay, so they can cause the PR interval prolongation by blocking the AV node. Okay, Asmolol has the very shortest acting time. This is also very important. Okay, And yeah, that would be it. You already know every adverse effect of these drugs. Okay, very important. And please remember, they do not have any effect on the myocardial action potential. Okay, although they are kind of acting and inhibiting the acting on the myocardium and inhibiting the calcium channels, the calcium influx, they just decrease the contractility in the myocardium. Okay, and as you can see, they are used for the supraventricular tachycardia, for the atrial fibrillation and for the atrial flutter. They are not used for the ventricular tachycardias because they have no effect on the rate of ventricular contraction in case of ventricular tachycardias. Okay, they have major effect only on the SA node and the AV node. Okay, then comes the antiarrhythmic class 3 agents: amiodarone, sotalol, dofetilide, and the ibutylate. Sotalol, it is a class 2 as well as a class 3 agents. It has a beta blocker. It has a beta blocker properties as well as the potassium channel blocking properties in the myocardium. Okay, so mechanism. If I talk about the amiodarone, it is a drug which has an action of class 1, class 2, class 3, and as well as class 4. Amiodarone can act as class 1, class 2, class 3, and class 4 agent. Okay, and it causes a minimal QT prolongation by blocking the potassium channels. It causes a minimum QT prolongation because all of the potassium channel blockers, they all can cause a QT prolongation. Amiodarone is the minimal one. Okay, because it acts as a class 1 agent, it can cause a QRS prolongation. Okay, it acts as a class 2 agent, it can cause a PR prolongation. It acts as a class 3 agent, it can cause the QT prolongation, and as well as by acting as a class 2 agent, it can decrease the sinus rate. This is for the amiodarone. For the sotalol, it is a class 2 and a class 3 agent. So for being a class 2 agent, it can cause a PR prolongation. Being a class 2 agent, it can similarly cause a sinus rate decrease. Okay, being a class 3 agent, it can cause a QT prolongation, but it had no effect on the QRS complex because it is not a class 1 agent. For dofetilide, it is only the class 3 agent, dofetilide, and that's why only causes the QT prolongation. Okay, at higher heart rates, they have a minimal effect, amiodarone and other drugs. Okay, they have a reverse use dependence at higher rate. They do not work properly. Okay, and that's why at a very high heart rate, they can cause a QT shortening. Okay, while in case of class 1 agents, because they shows the use dependence, they have the QT prolongation at high heart rate. So if they give you a patient, okay, and a history where where the exercising, after the exercising, the patient is having a QT prolongation, that means it is a class 1 agent. But after the exercising, if the QT period is decreasing, that means it is a class 3 agent. Okay, then comes the adverse effects, which includes the hepatotoxicity, okay, and the hypothyroidism and the pulmonary fibrosis. So you always have to check the PFT, TFT, and LFT before giving the patient amiodarone. Ibutylate can cause the tosa de pontis. Sotalol, it has an excessive beta blockade effect as well as a tosa de pontis, similar thing. Okay, and this amiodarone can also deposits in your cornea, okay, and cause the grayish and the bluish deposits in the cornea. Very important. When you look on the cornea, you will see the grayish and the bluish deposits of the amiodarone in the cornea. Any doubt?
No.
And finally, the class 4 agents. They are the calcium channel blockers. We have discussed them. They have an activity just like the beta blockers. They decrease the contractility. They decrease the heart rate. Okay. So similarly, they decrease the heart rate and the contractility, nothing more. But they have a special effect, which is a constipation. And I have discussed that why. Because they also sometimes inhibit the, mood muscles in the GI tract. Right. And there they can cause the constipation. Okay. Flushing edema is not a major effect of the non-dihydropyridine calcium channel blockers. They have a major effect of the dihydropyridine ones only. Okay, so flushing edema, you can just forget this part. Okay, not a major side effect of these drugs. Heart failure they can cause. AV block, just like the beta blockers, they can cause. Okay, nothing is special about them. Then other antiarrhythmics. Just give me a second. Other antiarrhythmics, first is the adenosine. Okay, adenosine, we have discussed that previously in the physiology part, that it causes the outflux of the potassium. It causes the increased outflux of the potassium so that the hyperpolarization can occur. This point, which is going here for the hyperpolarization, it will go all the way down here. So now longer time will be required to reach back to the threshold potential, right? And as a result, the heart rate is decreased. Okay, very important. So use these drugs for the paroxysmal supraventricular tachycardia, means those tachycardias which has a very shorter time, okay, which just come and go in phases. Okay, these are known as a supraventricular paroxysmal supraventricular tachycardia, which are for a transient time only, for some short period of time. You use these the agent adenosine in these patients. Okay, adenosine, their effect is blunted by the theophylline and the caffeine. They are the antagonists, like we have discussed previously. Okay, adenosine, because they have the receptors on the smooth muscles also in the vessels. Okay, they can cause the flushing by causing the vasodilation, and similarly they can cause the hypotension by causing the vasodilation. Very important. They can cause the bronchospasm. This is a very important thing. They can cause the bronchospasm. That means they are also involved in the pathogenesis of the asthma. So one of the therapy for the asthma is inhibiting the adenosine, and it is the theophylline. Does anyone remember the function, the mechanism of action of this theophylline?
Phosphodiesterase 3 inhibitor.
3. And what drugs inhibit the phosphodiesterase 3?
I don't remember the exact
I
phosphodiesterase.
think phosphodiesterase 3 is milrinone, right?
Yeah,
Rhesus.
enamrenone and abilirenone.
This one's not specific.
Yeah,
It
this
doesn't
one is
have
non-specific type. Okay, do not kind of non-specific type. It can inhibit 1, 2, 3, 4, 5, anyone. Okay, please remember this fact. So by because it inhibits the adenosine, it can cause the bronchodilation also. Then magnesium, it is highly effective in the torsade pontis. I don't know why, and it is also used as the digoxin toxicity treatment. Okay. Then the ivabradine, we have discussed that already. It inhibits the funny sodium channels, which are responsible for the depolarization. So if these channels are inhibited, the phase 4 will be prolonged. You will get a reduced heart rate. Okay. And yeah, so they're ultimately reducing the oxygen demand of the heart. So generally used for the chronic stable angina in the patients who cannot take the beta blockers. Sometimes they can also be used for the heart failure with reduced ejection fraction. Okay. And that would be it. It is not a major action of these drugs. Just remember for the angina, ivabradine for the angina mainly in the patients who cannot take the beta blockers. Okay. Adverse effects is the visual brightness, hypertension, bradycardia. Not a major thing. Okay. Just remember the function. The mechanism of action of this drug is very important. Okay. Which is the inhibition of the funny sodium channels. So that a depolarization or the phase 4 will be prolonged and the heart rate would be decreased. This is a major thing that you must remember for the ivabradine. Okay. So any doubt on this page?
How does adenosine causes bronchospasm? Can you elaborate?
It's just a that thing about receptors. Okay, just like how can I explain you this part?
This is a camp, CMP.
Yeah, it is somewhat related to cyclic KMP. Like the histamine that the histamine, it actually causes the vasodilation, but in the lungs it causes a bronchoconstriction, right? Because of different receptors. Okay, so they have a receptors like A1, A2, something like that. Okay, so different receptors of the adenosine found in the lungs that causes the bronchospasms instead of dilation. Okay, it's all about the receptor thing. Different receptors of the adenosine found in the lungs that can cause the bronchospasms, like the histamine 1, histamine 2 receptors, dopamine 1, dopamine 2, and something like histamine 1 and A1 and the A2 receptors are also there, right? That's any more doubt?
No, thank you.
No, thank.
So we are done with the cardiovascular system completely, with the anatomy, embryology, physiology, pathology, and the pharmacology. Okay. And from tomorrow, we will start the endocrine session and we'll try to finish in 1 or 2 days maximum. It is a short chapter because, okay.
Okay.
Thank you so
Yes,
much,
thank
everyone.
you.
I think we should wind up now.
Thank you so
Thank
much.
you so much.
Thank you so
Thank you.
much.
Thank
Thank
you.
you.